Okay. Good afternoon, everyone. Today is the day we begin to learn to look through the eyes of others, to find out and experience what the world is like for them. It is also the day we grow bigger than our differences and offer to everyone, regardless of historical rights and wrongs, a friendly welcome and outstretched hand. Jai Hind, on behalf of the management, principal, staff, and students, I take this opportunity to welcome you all on this auspicious day. I, Mr. Anand Semperera, Associate Professor, Department of Medical Surgical Nursing, is here to host the International Virtual Conference on Amelioration in Nursing Education, Research, and Clinical Practice, focusing on e-health in digital native era, which is organized by PANNA Subharti Nursing College, Swami Vivekananda Subharti University, Meerut, as a part of our annual College Day and PANNA Day. Before start, I would like to give introduction about our university. Swami Vivekananda Subharti University is a university under Section 2F of the University Grant Commission Act 1956, set up under the Swami Vivekananda Subharti Vishwavidyalaya, Uttar Pradesh, 2008. The seed by the name of Swami Vivekananda Subharti University was sown in the year 2008 under the leadership of our great visionaries, Dr. Atul Krishnan and Dr. Mukti Bhatnagar, as a subsidiary of Subharti KKB Charitable Trust, presently headed by our CEO, ma'am, Dr. Shaila Raj. The seed has become a much sought after fruit-laden tree, with being recognized as a accredited university by NAC in the year 2016. The university is a privileged higher center for learning and research, with emphasis being laid upon preparing the youth for the social order by imparting value-based education. The core values of this university are its four pillars: education, service, sacrament, and nationalism. The university boasts of highly qualified, dedicated, and competent faculty from all walks of life, world-class infrastructure, fully equipped laboratories with latest state-of-the-art equipment, and a huge library with recent knowledge resources, including e-resources. Dr. Shaila ma'am and VC, Honorable VC sir, to light the lamp. I thank our dignitaries for lighting the lamp and releasing our conference proceedings. Each day holds a surprise, but only we expect it can we see, hear, or feel it when it comes to us. Let's not be afraid to receive each day's surprise, whether it comes to us as sorrow or as joy. It will open a new place in our hearts, a place where we can welcome new friends and celebrate more fully our shared humanity. Welcoming the gathering is a gift. To present the gift on this day, I request the dynamic personality, the soul of our nursing college, the great mentor and the leader, none other than our principal, ex-captain Dr. Geeta Parvanda, to deliver the welcome address.
Jai Hind, Honorable Vice Chancellor Sir, all the esteemed dignitaries, guest speakers, and dear participants. I, Dr. Geeta Parvanda, as organizing chairperson, welcome you all in this international conference on virtual mode on topic amelioration in nursing education, research, and clinical practice, focusing on e-health in digital native era. Yukti yuktam pragatiyat baladapi vichakshanam. The wise should learn to accept wisdom from anybody, even from the child. Why can't we healthcare professional learn from digital technology? Education is a fundamental for achieving full human potential. The aim must for India to have education system by 2040, and there is second to none with equitable access to highest quality education for all learners regardless of social or economic background. As per the National Education Policy 2020, the Digital Indian campaign is helping to transform the entire nation into a digital empowered society. On the same, the theme of this conference is based on to provide the opportunity in developing learning managing system and improving the clinical reasoning skills. Today, at the platform, we have renowned speakers around the world who will be imparting knowledge using updated teaching methodology. First of all, I'm thankful to Professor Susan Edamala and Mr. Rinto for being as a member in the advisory board, and to all guest speakers who have given the consent in this COVID-19 pandemic time. My heartiest wishes and prayer to the participant my heartiest wishes and prayer for the participant across the nation who have registered, and we are sure that this interactive session and updated use of technology will surely impart views on strategies and intervention to improve the effective use of e-health.
Thank you so much, ma'am, for your valuable messages to all the participants, those who are present today. I indeed feel proud in welcoming the flag bearers of tomorrow. The university aims to provide skill-based education, thus nurturing committed and competent, well-trained and noble minds who are ready to take on the world with their levels of expertise and experience. The liberty of expression of one's free will and intelligence makes Subharti a perceptual source of learning, an encouraging and welcome word of a personality in our university. The blessings of the leaders are more valuable to enhance our talents. Here comes Associate Professor Mrs. Shaheen Akhtar Khan, Department of Community Health Nursing, to present the notes of blessing of our founder, Madam Dr. Mukti Badnagar, our VC Sir, our CU Ma'am, and our Dr. Krishnamurti Sir. I welcome Ma'am Shaheen Akhtar Khan.
A very good afternoon to one and all in this international conference organized by PANNA Subharti Nursing College. I'm here to deliver the blessings of our leaders of Subharti University. So first, we start with Honorable Founder Ma'am, that is Dr. Mukti Bhatnagar. I'm elated to learn that Pannadaima Subhati Nursing College, Subhati University Meerut, is hosting an international virtual conference on the theme Amelioration in Nursing Education, Research, and Clinical Practice, focusing on e-health in digital native era, and observing the annual College Day from 28th January to 30th January 2021. The theme of this international virtual conference is relatable to the exciting circumstances of pandemic COVID-19, where the health workers, particularly the doctors, nursing care providers, have been labeled as the frontline warriors and have been serving the mankind, keeping their own priorities at the last. The COVID scares, however, has been able to deter the field of education and research, and the focus has shifted from classroom era to the virtual mode. With the world shrinking to a global village, the things available at the click of a button, the healthcare providers also have seen a sea change in the way they are communicating with the world around. The focus has shifted from visit to the hospital until and unless absolutely necessary to consultation by means of telemedicine. The field, the nursing field too has caught up with the changing scenario and has kept itself a beast, be it in the field of education, research, or clinical practice. They have adopted to the new normal and have devised ways of communicating amongst themselves as well as with the patients. The nursing care is more of a quality now over quantity by electronic means of communication, and this has indeed proven to be a boon in this testing time. I'm sure that through this international virtual conference, the participants will be able to update themselves with the recent advances and latest happenings in the field of nursing and how the world is coping up with the pandemic so that they are ready to take the world head on. The galaxy of learned speakers should be able to mesmerize the participating delegates with their discourse and knowledge related to diverse field of nursing. I would like to extend my best wishes to unswirling and adorous efforts of Captain Dr. Geeta Parbanda and her team, whom I am in no doubt will be able to uphold the name of the institution as well as the university in the minds of participating delegates. Next, we start with the blessings of Honorable Vice Chancellor, Dr. V.P. Singh. It gives me an immense pleasure to congratulate Pannadai Masubhati Nursing College for organizing annual College Day celebration and international conference from 28th Jan to 30th Jan 2021. Virtual International Conference on Amelioration in Nursing Education, Research, and Clinical Practice, focusing on e-health in digital native era. Not only bring all researchers, students at one platform, but also inculcates the research culture among the entire fraternity of education in the country, hereby contributing to the development of the nation. I hope that this conference would certainly induce innovative ideas among the participants, paving way for new inventions in clinical practice. On behalf of university, I wish all delegates have thought-provoking in sessions and assure you to provide a healthy experience and warm-hearted memories to cherish. I would like to convey my best wishes to organizing team for a grand success. Next, we go with the blessings of the Chief Executive Officer, Madam Dr. Shelya Raj. I would like to congratulate Pannadai Masubhati Nursing College for organizing the international conference with the theme Amelioration in Nursing Education, Research and Clinical Practice focusing on e-health in digital native era. Digital education is increasingly used for clinical practice, guideline dissemination, and adoption all over the world. It has been increasingly employed in continuing medical education and professional development, offering a suppler, nominal, and approachable substitute to traditional learning that transcends the impediments of terrain and time. Nowadays, utilization of diverse media and delivery devices allows for encouraging an interactive learning resource beneficial for the learning needs of healthcare professionals. Evidently, the studies on nursing and medical students have demonstrated that satisfaction is constantly higher in a blended learning environment comparable with a traditional lecture setting. I believe this conference will be one of the finest opportunity for academicians, scientists, professionals, and researchers from all over the world to share and express their views also. The research concepts discussed during the international conference will evaluate interactive simulation based and spaced forms of digital education and reports on outcomes such as skills, behavior, patient outcome, and cost. Hope it will be a splendid event both in terms of intellectual quality and social gratification. Next, we continue with the blessings of Dr. Krishnamurthy sir. I am happy to know that the Pannadai Masubhati Nursing College is celebrating years of excellence and is organizing an international virtual conference from 28th January to 30th January 2021. The alumni of Swami Vivekanand Subharti University spread across the globe have made not only their alma mater but are making the university proud through their achievements. I'm sure that the virtual conference shall provide an opportunity for the alumni to network with one another and contact with younger generations. I extend my warm greetings and wishes to the college and the participants for making the conference a success. Thank you so much.
Panna Daima was such a famous, stunning, and compassionate woman who saved the life of Yuvraj Uday Singh of Mewar by sacrificing her son Chandan. The Maharaja of Mewar had selected Panna Daima as a nurse to look after his son Uday Singh. When the enemy attacked Mewar and tried to kill Yuvraj Uday Singh, Panna Daima, sacrificing her son Chandan to protect the life of Yuvraj Uday Singh. Protecting someone else's life by sacrificing her son is not found elsewhere in history. That's why her image is remembered. In history, her name is written in golden letters on behalf of her faithfulness. Pannadaima Subharti Nursing College is dedicated in her name. By following and serving her ideals, nursing students are connected with patients and community. Thank you.
Thank you, Shine ma'am, and for the nice video about the history of Panna Daima, why a college named as Panna Daima. I am proud to be a nurse and strongly believe that nurses are invaluable asset to society. I enjoy my work immensely and believe that mentoring, motivating, and influencing colleagues and healthcare providers positively in a unique way of paving the way for a better future for healthcare in the world. These golden words were delivered by the dynamic personality Ms. Susan Edamala. Madam Susan Edamala, currently working as a clinical nurse consultant for clinical documentation integrity at the University of Illinois, Chicago, and also an adjunct professor at the Rasmussen College of Nursing, Illinois, USA. She is a registered nurse with certification in critical care and clinical documentation certification with 29 years of nursing experience in India, Sharjah, and the United States. Madam Susan completed her bachelor's in nursing from Armed Forces Medical College, Pune in 1991, and her master's in nursing, clinical leadership and management from North Park University, Chicago, 2012. She had been a critical care nurse for 22 years and then moved into clinical documentation integrity in 2013, and also been able to maintain her teaching job as a visiting professor or adjunct faculty as a part-time job for her entire career. She had served as a board member at the IDPF or Working Force Center. She has been awarded multiple awards for excellence in nursing from various organizations and also had done multiple presentations at the state and national level in the United States and internationally. Ma'am, it's our privilege to have you today at this conference from USA. Ma'am, the platform is yours.
Thank you very much, Anand. I just want to make sure that you can all hear me.
Yes, ma'am.
Okay. Good afternoon to everyone in India. It is almost past midnight, actually 1 a.m. in Chicago at this time. So without much ado, let me start with my presentation. And what I'm going to present to you today is the impact of transition to blended mode in nursing education. So the purpose of this presentation is to discuss the impact of transition to blended learning in nursing education. And the evolution of blended learning model is not new to nursing. We have been using this, but however, the most educational institutions all around the world were thrust into this blended model forcibly because of the COVID pandemic. It brought unprecedented changes in social interaction, and so we were all forced to go into a blended mode. Implementation of blended learning programs requires administration, faculty, and the students to be in alignment with their goals. A robust infrastructure is a must, and continuous evaluation is imperative to the study and of the impact of learning on students, faculty, and the institution. So it is more than necessary in any time at our times to come up with this topic for deliberation, because most of us, whether we like it or not, will have to implement this in the near future. Actually, we are doing it now, so that the world becomes one platform and we can exchange knowledge and skills and attitudes from each other. So this presentation will discuss on the specifics of the impact of blended learning methodology very comprehensively. The objectives of this presentation are as follows. We will define what blended learning methodology is. We will discuss the conditions under which sudden thrust of nursing education globally went into blended mode. We will enumerate the impediments in preparation of educators and students for the new methodology of education. We will examine the advantages of blended learning. We will enlist the disadvantages of blended curriculum. We will comprehend the effect of blended learning on student learning and performance. And we will deliberate on the future of blended technology, teaching methodology in nursing curriculum. Now, what is the definition of blended mode? According to Oxford Dictionary, a style of education in which student learns via electronic and online media as well as traditional face-to-face teaching. So it is both. It's not just being the didactic, the conventional method of teaching, which was in the classroom and the clinical setting in the hospitals, but it is also using online technology and online media for educational purposes. So when we use all this media together, then it's called blended mode. But for now, during the COVID pandemic, we see that we are restricted on our face-to-face classroom interactions or even on clinical sites, but we have chosen more to do as online, using the various online platform for learning. So blended learning is a combination of digital learning, which can be accessed anywhere the student has internet access.
Ma'am, sorry for
24
interruption. Ma'am, are you changing the slide, ma'am? The first slide only is there,
I am changing the slide actually.
but it's still the first slide.
Am I on the introduction slide still?
Yeah, the first slide, impact of transition to blended mode in nursing. Only that is there.
Okay, so then I don't know what's going on here, because on my computer I see that I am moving it. So you know what, I'm going to stop sharing. Maybe you can share from there and then I will just ask you to move it forward for me. Shall I stop sharing now?
Ma'am, you can exit the share content and again you can share it.
Okay. That's
Once again you share it.
All right, so is it working now? No?
No, ma'am.
You have the slide. I've sent the slides to you. So if you can share it, then I will just go along with as you move the slide forward.
Okay.
All right, ma'am. We'll just organize it. Just give us a minute.
Sure. Take your time. No problem. I'll try one more time. Let me see. Tell me if you can. Can you see my screen now, Anand?
No,
No, ma'am, screen.
no, no.
No?
We can see it, ma'am, but I'll share the screen. You can see it on your screen as well, what we see.
Okay.
It's the first introductory slide that you have, but you've shared the PPT itself. If you share the slideshow, then it'll run as a slideshow.
Yeah, so it was running on the slideshow actually.
Okay, no problem, ma'am. We have your PPT open now. I think we can run it from here.
Okay. So I'm going to close my PPT, okay?
Sure, ma'am. Sure.
Okay. All right.
All right. So we have
So,
it open now.
yeah, so I will start over or
No, we can just skip and move to the page where you were. So we
yeah,
have the
so
introductory page.
okay, so we talked about the introduction, go along. Yeah, we talked about the objectives of the presentation, and I hope everybody got an idea about what the presentation is on. And we also talked about, yeah, can you move to the next slide? The definition of blended mode, that's pretty straightforward. Move to the next slide. Yeah, so now we're going to, let's go from this slide onwards. So the whole world globally, we went into this blended mode of education during the COVID pandemic. Now it has become a new normal for everybody, and it is because there is inability to travel due to lockdown in many places at different times in the world. Throughout the globe, we have seen that different countries and different places have been and lockdown at different times. And so because of restriction of movement, and even if we were after the lockdown, when we were allowed to go back on sites, we could not have the same number of students because we had to have limited numbers as per the regulations of the state. We have the Illinois Department of Public Health, which would ask us not to have more than 6 students in one room, and with a 4 to 6 feet distances. So we had to actually have lots of restrictions and lots of adaptations to make. There was lots of resource management techniques that we had to employ to keep our curriculum are going, and our students still being able to meet the learning objectives. And the hospitals were focused on patient care burden, and so a lot of hospitals were closed down for the students because they could not have staff for precepting the students, or even because of the limited supply of the personal protective equipment, we had to really go into the new normal mode, which is the blended mode of teaching. Can we move to the next slide, please? So what are these challenges that we were suddenly thrust into because of this, adapting to a different mode of teaching altogether? So there are courses that were already in our university. Online courses are there for a lot of courses like pharmacology, anatomy, physiology, and those kind of courses. But when it comes to courses which has to have a lot of a heavy part of clinical learning, where you have to use your hands to have a real patient, those kind of although there are simulations for that, we still use the hospitals for real life experiences for our students. So actually for me, I remember it was March 14th of of 2020, that we were in the clinical setting at that time, and I was called by the dean of the university, and I was told that I have to just leave the hospital immediately. So I just had to gather my students and tell them to leave the hospital premises within half an hour. And they said whatever, how they're going to implement the rest of the thing will be told to us later. At that point of time, it was that we should just leave the hospital. So it wasn't, I mean, so we were surprised and we wondered what we are going to do and how it's all going to work. And we were suddenly thrust into this online learning environment without much experience. A lot of us never had teaching experience online, and there was not enough time to actually train everybody to the best. although we have platforms that are very good, we couldn't actually keep up with, we had to learn a lot. It was self-learning, self-teaching, and teaching each other, calling each other every now and then to figure out which tab to click, where to go, what to do, because when the student asks us, we have to know what we are doing. So all together, it was a very, very stressful semester for us. And then technological scarcity, although I mean, people would think you're in the United States and everything should be available to you. There are students who are very poor, and who don't have internet all the time, or probably they don't have all the technological things that they need, and lack of infrastructure is also a reality for some of the students. Can we move to the next one? Yeah. So how do we come to terms with these challenges, and how do we overcome them? It is only possible through strategic preparation for the blended learning mode, and I think that is what the Subharti university is also trying to do, because now in an international forum, or in the international conference, now we are talking more about this, because this method of teaching is going to stay with us for future. So we need to know more, and we need to get prepared for it. So it is more necessary now than any other time in our career. So we need to have, so if we are going to have this mode of learning, then what we have to do is we have to have a uniformity in the learning management systems that we are using throughout the school, and for all the courses, so that we give the same content to all the students. And we should have minimum things that we should have is the learning management system in place. We should have file storage and sharing tools available to us, and we should have meeting platforms, and we can use methods like virtual instruction sessions, recorded on demand lessons, live lessons, and virtual office hours for one-on-one attention to our students. Can we move to the next slide, please? So what are the advantages of blended learning methodology? Actually, I think the advantages are much, much more than the disadvantages, and we will look at a few of them. A learning management system is where the instructor puts all the lessons and activities that the students must work through to successfully complete this course. So there's a blackboard, or a different kind of management systems that is available to us online. Is Blackboard is one of them, Canvas, or Google Classroom, Moodle, or Virtual Classroom, or WebEx. These are some of the platforms that I have used. And what we have to do is, for each course we have a course shell, and then we have weekly lessons that we have. For theory, the lessons that we have planned; for labs, the lessons we have planned; and for clinicals, the lessons we have planned. And then we have the modules, that what is included in the lessons is all put before the course starts. So the students have the access to this, and they can go and look at how much of time they need to spend on each of their activities. So it will better prepare the student for their future learning too, because especially in United States, like, we cannot work as nurses unless we do our licensure exam, which I'm sure you're familiar with, the NCLEX exam. So you can pass from the nursing school, you can finish your associate degree, bachelor's degree, or a minimum is a bachelor's now in nursing, and then you will not get a job unless you do your NCLEX exam, which is given to you by the state board. And once you do that exam and you pass that exam, then only you are qualified to work as a registered nurse in any hospital in the state, in whichever state you practice. So that exam is online. It is not a paper and pencil exam, and it is a computer adaptive exam. And now they are changing that to the new generation NCLEX, which is like, it's almost like a video game. Like, when you go into a patient's room, on the computer, and then you meet the patient, you talk to the patient, and the patient will respond to you. So it's much like the video game. So when we are going into the blended mode, the students are getting more and more exposure to such platforms. So it is better preparing them for their future learning and future work. And we know now, because of telehealth and all the things that is remote now, it is more important now for everyone to become tech savvy and to adapt the ways of technology into their daily life and daily practice in whichever profession they are. So nursing has to be in par with all other professions, and because ours is a service profession and we have to deal with people, so we have to keep up with the changes that is going around us and keep abreast with the latest technology and knowledge. In the another advantage of blended learning is that teachers have the autonomy to be as innovative as possible, so they can actually include a lot of games, puzzles, quizzes, which is like not just like a test that you give in the classroom. You can make it much more interesting. You can have games, painting, and so many different ways of delivering the content to the students. And students with learning difficulties, they do much better, because in a regular classroom, when you have a weak student, sometimes the student doesn't want others to know that he's weak, so he or she probably is quiet and doesn't participate so much. But when they are alone and you have a one-to-one time without anyone else in the virtual office room with them, they tend to do much better. And same as with introverted kids, they also are less shy to speak up and to let the teacher know where their difficulties or struggles are. So it is very helpful for those introverted students too. And there is flexibility in terms of availability of resources on an online platform versus in the classroom. And we are able to tailor it specific to each student's need. And you can actually ask the students where they are exactly struggling, and you can spare a little bit of time. That's what I do with my students. I ask them, even if I'm teaching medical surgical nursing, and they would say they had a test in mental health psychiatry, they were having some difficulty with something, and then you can discuss it, and students will feel very much very much close to you, or you will establish a really good rapport if you're able to help them with their difficulties, even if it's not your subject. So you may not know everything, but you can always say, you can look up, and then you can get back to them and try to help them. So that way this gives you more room for discussions, for flexibility, and for adapting your or tuning up your teaching skills to meet the needs of your students. And privacy can be maintained. If one of your students, you can see in the classroom, when you are seeing them, they're not concentrating, or they are looking away, or they're talking to somebody else, and they put put themselves on mute, or they just disappeared from the scene. You can privately chat, and you can let them know, I'm watching you, I'm seeing what you're doing, and you're accountable for your actions. So there are a lot of advantages, as far as I know, compared to in a classroom teaching. But definitely, if you would ask me, would I want to be teaching at the bedside in clinical, or online clinical, I would definitely say it would be at the bedside would be the best. But then it has got its own good and bad. So what are the disadvantages? So disadvantages are usually, it happens only when we have lack of training or support for both teachers and students, like how it happened in March last year. Suddenly we just jumped into online without knowing anything properly, and we had no resources, or we had I'm sure our dean and other faculty members were struggling hard to put everything together for us. They've had sleepless nights trying to get everything in place, but even so, it was difficult for all of us, including the students and the teachers who were delivering the content to them. Inadequate technological know-how, that's why we were struggling. So in the beginning it was very difficult, but as semesters go, we have become more and more adept at what we are doing, and we feel more comfortable. Technological glitches is another problem. You just saw now with my presentation here. I was going very smoothly and wonderfully, and suddenly I was told that, yeah, my slides are not moving, and then it wastes some time trying to get back to where we were. So these kind of glitches, no matter how well we prepare and practice, it still can happen. But the only way we can overcome it, that is by accepting, yeah, these are things that can happen, and then just go from there. There's nothing else to do, right? So we just have to continue. And then one of the things that I have a lot of issues is distractions, that my students are not able to focus as much, and I, as a teacher, I need their attention all the time. I look at my students' faces all the time. So if I feel someone is not concentrating, I will call on them. That's because I draw my energy of teaching from my students. So if I see them not interested, I cannot continue teaching. So pets, dogs barking, or kids crying, or family members distracting them, these are things that are there. And there's only so much you can control, but sometimes you have to actually tell them to stop and concentrate in what you're trying to say. You have to hold them accountable. And sometimes there are glitches, so there's no IT support timely. So as of now, we have IT support there. Anand was trying to help me out, and others were trying to get my PowerPoint slideshow continuing. So sometimes you somehow cannot reach people on time, or they cannot reach you, and so you'll have to actually reschedule your session because you had an IT glitch and then there was nobody to support you. So these are the realities of blended methodology of teaching, where we can have some issues and problems. So now, what is the effect of student learning and performance using these methods? So there are some positives and there are some negatives. So positive is that it is an ideal learning environment in the sense that students can get everything they can get, to the fullest. So you can actually, everything can be so pre-programmed. So we can think thoroughly through something, and thoughtfully we can plan our case study, and we can carefully integrate every aspect of what we want the students to learn based on the objectives. We can make it very well organized and predictable, and we can focus perfectly on the objective, so we will not be wavering away from the topic or wasting time trying to go off the topic or anything like that. And we can do a well thought out plan. We can have a calm environment, and we can provide a wholesome learning opportunity for our students. Those are the positive things that the students themselves have told me, because when I was told to deliver a presentation on this topic, I asked my students, because they have also been thrust into this environment, and some of them are enjoying it, some of them are not enjoying it so much. The students who have children, like who have kids, they are really happy that they can still continue to study and be at home and even do clinicals from home. But not everyone is happy. Some people like the real human touch, so they miss that. I miss that personally. So the negatives are like lack of a real world experience. So we are hoping that we won't have to continue, especially clinicals, online all the time. We would be able to go back to the hospital, have a real world experience. However, for theory classes, I would say that online learning is very good, because you don't have to go to the classroom. You can sit at home, and you can still have the content that is given to you. Most of the time the lectures are recorded, so the students can go back and look at the lectures, try to understand it over and over till they are able to understand what exactly they need to know. So and another negative is like unforeseen turn of events. So sometimes, like for example, in the real world, when the students are in the real world, you have a certain objectives for them that they have to learn for that day. But then there are some things that happen. Maybe your patient had a code blue, or maybe the patient had a sudden event that was not foreseen before, and so because of that you have to change your plans. So you have to be flexible, your students have to be flexible to understand that things can go out of hand. Everything is not under your control, and you might have to reconsider your plans, reconsider your learning objectives. And sometimes the chaotic environment in the hospital, in the clinical setting, is not under our control. So although we want our students to have the perfect environment, most conducive environment for our students to study, many a times that is not available to the students. And how I teach my students is that That is reality. That's the real world. And in real world, nobody can predict anything, but we just have to adapt. And that is one of the things that as nurses, we have to have the skill for quick adaptation. So these are the negative things which the students may not learn if you just keep them very protected in their homes in front of the computer. The real life experiences will not be there for them. So that is why we want to have this as a blended education, not just one method. We want to have the lab, the simulation, the classroom, the recorded lectures, and the platforms, the clinical platforms, as well as the hospital. If we have all these facilities for our students, then for sure our students are going to turn out to be assets as best nurses for the society. Can we go to the next slide, please? Next slide, please. So now I'm going to go over the literature review of a few of the studies that were carried out in relation to blended or online learning or digital learning. So this, the first study that I looked at was the online blended learning paradigm that was, to enhance teaching clinical skills for undergraduate nursing. This study was done by Vrije University in Brussels by Min et al. And what they found was that online learning for teaching clinical skills is no less effective than traditional means. So based on their research, they found that it is as online learning, even for clinical skills, is as good as the traditional learning in the hospital. Can we go to the next one? So this is another study that was done by Kant and Cooper in 2010. And this study was to determine whether the use of online blended learning paradigm has potential to enhance teaching clinical skills in undergraduate nursing. This is another study. And what they found was that there is a wide, varied, and expanding number of blended learning approaches that is currently being used in nursing education all over the world. And so they are actually recommending that more and more such studies should come up so that we have a pool of research wealth and evidence-based practice which will support blended learning in nursing curricula. Can we move forward? Next slide. The next study is about blended learning in undergraduate nursing. It's a scoping review, and it's done by Liedl et al. And this was published in last year, in March 2020. And the objective for this study was to do a comprehensive scoping review for regarding the use of blended learning in undergraduate nursing education, and to align varied educational terms, definitions in broad definitions in blended learning. And what they found is a variety of blended learning approaches are being utilized in undergraduate nursing education, and the majority of which are happening in the classroom. So even before we went into the COVID situation, and where we were forced to go into online mode, we were using, to certain extent, we were using the online platform, but we were not doing separately. Like the students were sitting in one classroom, and then they had activities that they had to do, like look at a video and write a brief description of whatever they saw, or their thoughts on some ethical issue or something that they have seen online. So those kind of things. So, but it was still delivered in the classroom at that time. Can you just move to the next slide, please? So this is another study, another scoping review by Josie and et al. And what they found is that when blended learning is delivered purposefully and effectively in terms of managing and supporting students' active learning, it positively influences the achievement of students. So if, when I talked about the challenges and the disadvantages, if we as an organization are well prepared, the administration, the students, the faculty, and everyone is in alignment with this methodology, and all the support that is necessary, the infrastructure, the platforms, the technological help that we need, the IT support people, and all of them, and IT education also for us as nurses, as teachers. Actually, we need it more than for our students, because we are the ones who actually prepare the course shell. We prepare the exercises for them, how they have to complete their assignments and upload it into Dropboxes so we can look at it. And if there are platforms that they can go and do. For example, they have a patient. We in one of my semesters, like last semester, I had a platform called as Shadow Health, or virtual simulator, VSIMS. It's from Walter Lippincott textbook. They have VSIMS. So if you have a VSIM, you are teaching on, say, CHF, you have a patient with CHF. So when they do CHF, when they go into that VSIM module, they are able to actually interact with the patient, and they are able to give health education. They are able to do a full head-to-toe assessment on these patients. And we can actually look at how many attempts they made. So they cannot finish that unless they get a certain score. For example, for them to pass, they have to get 80%. So until the system will allow them to take this, to do this exercise over and over until they get to 80%. So we will be able to actually know, as a teacher, when you go back and look at how many attempts they have made, you will be actually able to see what was their critical thinking, how did they come up with certain clinical judgment skills and stuff like that. So you will learn, so in the beginning, when the students start with this platform, usually they are very slow and they are kind of trying hard to meet up the expectations. But almost once they do 3 or 4 of those, and then they are able to actually get the hang of it, and then they are able to perform more well, and they are able to critically think, okay, if my patient is having the G tube, if I keep on aspirating and the patient is having a G tube aspirate of more than 300 or 350 cc, what am I supposed to do next? Why should I actually inform the doctor what's going on with the patient? This kind of critical thinking skills, the module will actually force them to think and come up to the answer. So these platforms are very helpful, and we can actually see their progress on how they are doing. We'll go to the next slide. So this is another blended learning on medication administration, integration of e-learning and face-to-face instruction in the classroom. And this study was done by Sung and et al. And then the conclusion for this was that blended learning, integrating e-learning and face-to-face instruction in classroom is useful for enhancing medication knowledge. An e-learning program can reduce the lecturing time and cost of repeated topics such as medication, and suggesting that it can be effective component in nursing education program. So even when I do a blended method, even for during medication administration for my students. So how we are using technology here when we are administering medication is that when I go with my students to pass medications to my patient, I tell them that today you are going to do medications for this patient. So they have to go and write down all the medications that the patient has, looking at the electronic health record of the patient. Once they look at all the medications, then they have to go into another platform called Micromedics, which will give them, it is built into the patient's EHR. So they just have to right click on Micromedics, and it will give them all the information about the medication, the indications, the side effects, the patient teaching, and everything. And then once they prepare everything, then they come to me, and then I ask them, what would you do? You're going to give the patient metoprolol. So what are the things you're going to do? And what is this medication? What class of medication it is? And if it's a beta blocker, what are the things that you're going to be looking at? Did you check the patient's blood pressure? How much is the heart rate? Is the patient able to swallow? Is there any restrictions for fluid intake for this patient? So all those kind of things. So we use the EHR, we use face to face, and then we go and we use a scanner to give medication. So in US, there was a study conducted. I forget the time, but maybe about 20 years ago or 30 years, I'm not sure, where they had conducted a study and published a paper saying that, to err is human. I'm sure some of you must have read that research or article. They talked about a lot of errors that happen in the hospital is related to medication administration, and to prevent that. And it is not always the fault of the nurses. It is sometimes system error. A lot of times it is system error. So to avoid and to prevent this, we have something called as medication safety. And we have a lot of steps that we practice when we pass medications to the patient. So we cannot pick up any medication like how we were practicing when I was a student nurse 30 years ago. We had a cupboard. We used to pick up the medication that we were supposed to give to the patients, lay them all on a tray, and then we take, and then we just go ampicillin 2 capsule. We just give it like that. So now you can't do that because the patient, the medication comes on the patient's name, and you have to actually go onto the computer, log in your ID, take the scanner, scan the patient's name, and ask his name and date of birth, verify it with the name band, scan the medication, scan the name band, then scan the medication. And if the dose of the medication that you're giving is not right, it will not let you proceed. So you're using technology, and the technology is actually preventing you from medication errors. So only if your dose is correct. So if suppose you picked up a 20 milligram tablet and the dose is 10, and then it will ask you, are you sure you are giving 20? Are you sure? So then you have to say, oh no, I am supposed to give 10. So you can actually take out the tablet, make it into half, and put it in the computer that you are giving 10 only. So that's how you ensure medication safety. Another thing is when a nurse is preparing medications, there is a red zone. So the Pyxis, the medications are not stored in a cupboard. It's a Pyxis, and where you actually put your fingerprint. So you put your fingerprint, and then only you have access into that cabinet. And then you put the patient's name, and then you select the medication. If you select something that is not for the right time, which is like in the evening, it won't allow you to take out the medication. So there are so many different levels and different steps of how patient safety is ensured. And so this is all done because system errors are the ones that make people make mistakes. Also, it's very important that nurses, when they give medications, they should be very concentrating in their medication. So we have this red zone. So when a nurse is preparing the medications, she's in the red zone. No doctors, no respiratory therapists, no student, nobody should disturb her, no phone calls even. So if she's doing that, she's only concentrating on that. And when she comes out of that red zone, then she's able to actually, do whatever she wants if someone's calling her for something. So we want to make sure that there is no errors at all. So these are the different methods, different mechanisms that are in place to prevent medication errors. And you know that we live in United States, we live in a very legally conscious society. So even a small mistake will cost millions of dollars for the hospital. So everybody is very, very careful. Otherwise, patients are very smart. They will sue you and they'll sue the hospital. So we have to be very, very careful about it. Can we move to the next slide? Okay, so this is a study on simulation in the internet age, and so this is a place of the place of web-based simulation in nursing education. And we here in the United States, we use simulation. It's a huge part of our nursing curriculum. Every course has at least 1 or 2 days in the simulation lab, and we send in students. And the whole thing is like the students go in and we can watch them from outside. So if I have like 8 students, then 4 will go in as a first batch and 4 will wait outside. The students inside the room cannot see us, but we can see them, and we have cameras also, and they're being watched and they're being recorded. And we will give them a scenario about, say, a new admission who came with say drug addiction, and so whatever are the objectives that we want in this scenario is all built, and we have support from the sim manager, and we have lab assistants who will help us, and we have different role players. So role players playing the doctor, role player playing the nurse practitioner, and these students go in, they do a head-to-toe assessment. If the patient has breathing difficulty, then according to the scenario, they're supposed to be putting the head up, giving oxygen, and so we actually evaluate them. It's not a punitive thing. So we pre-brief them before they go into simulation. They do their simulation. So simulation runs for like, say, 20 minutes. So the pre-briefing really takes like 30 minutes because we are talking about the disease process of, suppose it is about bronchial asthma, then we are talking everything about bronchial asthma. They're supposed to do homework and bring a ticket to entry, which means it's completion of all the things that were required to go into that sim lab. So once they are theory-wise, they are totally they are aware of every situation that is there with that system or that disease process. Then we ensure that we discuss that for 30 minutes. Then they go into the sim room. They do the sim for 20 minutes. Then they come back outside, and then we all sit together, and then we do the debriefing. So in debriefing, we are actually talking about what went well for them, what is the one thing that they remember from this. So most of the time the students are overwhelmed, they are upset, and they are angry, or they are sad, or sometimes they are like they hate it. And so it's a time when they will verbalize their feelings, and we tell them that this is the best place to make mistakes, because it is not real life situation. And if you did your simulation perfectly, you had no mistakes, that means you don't learn much, because we do have no opportunity for discussion. So simulation labs, I love them. It's very, very interesting, and students feel rewarded after everything is over. I've never heard a student who says that we don't like simulation. So it's a in thing here. I'm not sure how many colleges in India are using it, but it's really worth it. It's really worth the learning process. Next slide. So those were some of the studies that I quoted to show you that how far we have come, how much of gadgets and technology is there to assist us in learning. One of the things that we had in the college that I used to work in, Resurrection University, was somebody donated this, I don't know how many thousands of dollars, an anatomage model, which is like a huge, it's like a huge TV thing. You can actually make it lie down as a table, or you can make it stand, and then you can touch and take out each organ. And the patients that are loaded in there, they are real patients, like real dead bodies were loaded in there. And then they have like, you want to see a cross section of the lung, or you want to see so if this patient has had liver hepatitis, say alcoholic. There was one patient with alcoholic hepatitis, which I was there when I was looking at it. And then we cut his liver to see how his liver was. Like, everything happens on a screen. We don't touch the real patient, but it's so real when you look at it. And then the scarred tissue, or like the lung tissue for a smoker's lung tissue. So so the experience for the student becomes real, very real. Like when you teach certain concepts, like in bronchial asthma, what happens to the bronchioles. And so if you pick up a case with bronchial asthma among the loaded patients in that list, and then you compare it with another patient with a healthy lung, it'll exactly show you what the difference is. So this methodology of technology that we have for learning it's beyond what we can imagine. And it's very good that we have certain such things, because when we were students, we only had I remember the beautiful, colorful anatomy and physiology books that we had. I mean, we were fascinated even with that, but these days the students have a lot more to to rely on. So we expect them to be better nurses than what we are, right? So the future of blended nursing is like, it was new, and then it became normal, and then it will replace traditional learning methodology sooner than later. So it is very important that each of us become adept at it, become competent, confident, and use it in our everyday life. So Indians are supposed to be way ahead compared to other parts of the world when it comes to technology. So I'm sure that our world will be much faster, and we have to catch up pace with the rest of the world. So to summarize, what we discussed today in this presentation was that we talked about the specifics about the impacts of blended learning methodology very comprehensively. We defined what blended learning is. We discussed the conditions under which we were suddenly thrust into this situation. We talked about the different disadvantages or impediments that we have as educators, with this new technology. We examined the advantages and disadvantages, and we also understood the different, how it impacts the students' performance and learning. And we also talked about where we will go from here for the future. So this is what we discussed in this presentation today. Next slide. Next. So these are my references that I use for this simulation, for this presentation. So if you all have any more, you want to go through those research articles, the link is all here. So you can actually go and look at those research articles. All right. So if you have any questions or anything, the forum is open for discussion. If somebody has any questions, if I don't know, then I am sure you have some people who are more better than me who can answer the question. So yeah, so I would welcome questions from you guys now.
Yes, ma'am. There are three questions.
Mm-hmm.
Let me shoot out first. Can we completely replace the clinical setting scenario, which is very much required for the training the nursing students with blended mode of teaching even after the pandemic situation?
So as I already mentioned in my presentation, we work with, so nurses, we work with real patients. No matter how well we can train somebody on a mannequin or on a dummy, you have to have the real touch. No matter how good the technology is, the lung sounds, when you hear a real lung sound versus a lung sound on a mannequin, they try to mimic and make it most close to human, but it's still not real human. So it's just like how the EKG, when you learn the EKG on the textbook, it is perfect, beautiful P wave, perfect QRS, and perfect T, right? But when you go on the floor and you just look at the EKG monitor, it just looks like some designer rhythm. We don't even know what rhythm it is. So so it is like that. So since we are going to be working with real people, if you ask me, should we go on totally online and not meet the patients, it wouldn't be a good idea. It would not be. But to make someone learn the concepts, instead of making them make mistakes on a real patient, we can allow them to make mistakes on mannequins, right? That is safe for the mannequin, that's safe for us and safe for the patients. So once they learn the concept, then we have to take them to the clinical. So without a real clinical nursing education, I don't think will ever be complete.
Yeah, that's right. And one more, during this online teaching session, it has been observed that there is an increasing shortfall in the learning outcomes of the students. So how can we cope up with that?
Learning shortfalls meaning what are you actually measuring? Are you measuring their clinical judgment? Are you measuring their critical thinking? Are you measuring their response to question answers? In which term are you saying that their performance is not?
About their judgment and critical thinking.
How are you testing it?
We are giving giving questions to them what we are conducting the classes and about the response, how they give back to us.
So now so there can be 4 levels of questions. Okay, first level would be just in based on Bloom's taxonomy. This is what I'm saying. So level 1, level 2 questions are those that which you are telling them to just what is the normal level of potassium, or say, you know, how does the glomerular filtration minimum, what is the rate, or something that they have memorized, or explain the circle of Willis, you know, for example. So those are things that are from memory. But as a nurse, when you stand on the floor, nobody is going to ask you to draw the circle of Willis, or nobody is going to tell me how the systemic circulation happens in the body. So for those things, for your students to be able to for you to test their critical thinking and clinical skills, you have to actually, as a teacher, you have to give them questions which are asking them not anything directly. It's asking them to synthesize the knowledge that they have acquired through their learning, through the anatomy, physiology, pathophysiology, pharmacology, principles of physics, microbiology, all these things, and then they are giving you the answer. So for example, if I put a question like the same thing, like the G tube, I was talking about the G tube feeding. So they are saying, you know, you give a scenario and you give you give that the patient was unconscious and lying with septic, he was in sepsis and went into shock, and then now is become a long term patient, where is unresponsive because of sepsis, ended up having a tracheostomy and now is bedridden and now not responding, so has a G tube and you're feeding through the G tube. So that is your scenario. And the question is like, you went to give medication to the patient, and the patient is on continuous feed, which is like 80 ml per hour with 100 ml of flushes every 4 hours or every 6 hours or so. This is the patient has been tolerating and there was no problem, and then you go in and you're giving medication and you aspirate because you want to check whether the patient is tolerating the feed, and you aspirated 1, 2, 3, 4, 5 syringes of 50 cc's, and you have removed like 350 cc's now. And what is your next action? What would you do? So in this situation, the student needs to understand why this patient is not, what is happening now, what is happening. If the patient was okay till now, is it okay for me to just give my meds and go, or is it not? Is there something that I have to inform the charge nurse, or I have to, as a nurse, student nurse, should she inform her preceptor or her instructor what she sees? If she's doing that, that means she's critically thinking. If she's not, then she's not. So it all depends on what kind of questions you're asking them. If you frame a question nicely, and the good thing would be for you to know is like, if say 70% of your students made a mistake in that question, then you have to look at your question.
Yeah.
Right? Because maybe your question, the way you asked it, sometimes it's normal that it's clear in my head, but it may not be clear in the student's head.
Yeah.
Okay, so it depends. So even when you make questions, it's good for you to actually let someone else also look at the questions before you actually give the questions to the students. And also, if a lot of students are not getting it right, then what we do here is actually we scrap off that question. We don't consider it. So then we so it's lot of taxing on it's not that simple on the teachers. It's very hard for us to actually measure somebody's clinical judgment and critical thinking. It is because unless you give them questions which are like make them think and not give them the direct answer, or or for example, if the patient says, just get out of my room, I don't want to talk to you, so what would you do? So like, there are things that how would you approach the patient? Would you say, don't worry, I'm here to help you? Or you have to know what stage of anger the patient is in, or why is he upset? Or telling the patient, just sit down there because I am telling you to sit down. Those are not things, that's not therapeutic communication, right? So if the student has learned about therapeutic communication, then if the student is applying that, we know that the student, so maybe it's happened, she learned therapeutic communication in mental health, in psychiatric nursing, but now she's in medical surgical floor. So is she utilizing what she learned in that situation in this? So is she transferring knowledge from one concept to another? Is another thing. So if we want to make good nurses on the floor, we have to have people who are thinking, not people who are obeying orders. So I tell my students, if you have to only obey orders, if the doctor says come here, you come here, the doctor says go there, then why do you need this education? Why should you go to school for 4 years and get a bachelor's degree? You don't need it. You need that because we want you to be proactive, thoughtful, critical thinking, having good judgment skills, good assessment. Only then you save your patient. Not after the patient is coding, you will save the patient. You will save the patient much before you have good clinical judgment, good assessment skills, and you're able to pick up small little cues from the patient's look, from the eyes, from the lips, from the touch, the temperature. You are able to gather assessment data on this patient and call the resources that you need on time. Only if we prepare such good nurses, our patients will be safe. So we have a big responsibility as teachers to make this happen for our students. So it's not enough to just blame the students and say, oh, the students are not doing well. We have to sit back, that's one part of it. And then we have to actually think globally, look at like all the teachers together and see why this is happening. If it's happening, how can we make it better? It's not easy, but that's the only way to go about it.
Yes, ma'am. So that's all, ma'am. It's nice class you had with us, ma'am. And I thank for your presence over here because it's
My
I think
pleasure.
maybe 1 o'clock or 1:30
It's
midnight
going to
there.
be 2 o'clock. It's going to be 2 o'clock in the morning.
Okay, but you have spent such time with us and you're explaining in a very excellent manner. It was a thought-provoking session you gave to us. Thank you so much, ma'am, for your time and for your concern to be the speaker here. Thank you so much, ma'am.
Thank you. It's my privilege to be with you all, and thank you for considering me worthy for this. I truly enjoy teaching. I enjoy being with students, and I enjoy, participating, learning with, with each other and from each other. So this was a very rewarding experience for me too, and I thank Geeta and all of you for giving me this opportunity. And good luck and all the best to your Subharti PANNA Daima Subharti Nursing College, and all the students. Are very hearty good luck wishes from me, and um, thank you so much once again.
Thank you so much, ma'am. Thank you, ma'am.
Thank you.
So it was an amazing and thought-provoking session we had by Mrs. Susan Edamala. And now the next section is how 2020 flipped the nursing education. She led a vibrant role in her career of 37 years, starting from bedside in India and abroad to being the group nursing head of Fortis Healthcare Limited. She has spearheaded in setting nursing standards and quality assurance in Fortis. She is recognized as a skillful orator and invited in nursing conferences nationally and internationally. She has a keen interest in research and evidence-based practices. She is head of education and Berkeley Education EDU, has worked with medical and nursing colleges to collaborate and include simulation-based learning during the formative years of doctors and nurses. She is dedicated to developing nurse leaders as she strongly advocates that nurse leaders need to become nurse-centric so as to nurture young nurses to become patient-centric and develop into influential leaders of tomorrow. She is the co-chair of the Task Force for Nursing Reforms of FICCI and is frequently invited to special groups formed by government and Delhi Nursing Council as a subject matter expert. She collaborates closely with national and international simulation experts to conduct high-fidelity simulation training programs for doctors and nurses. She is a founder member of Infusion Nurses Society India, member of American Association of Critical Care Nurses, American Organization of Nurse Executives, and a lifetime associate member of Indian Society of Critical Care Medicine. She has undergone special training in simulation and debriefing from Jurong Health, Singapore, and further honed her skills to be a trainer under Dale Scannick's TTT program. She is also an American Heart Association certified BLS ACLS experienced provider instructor. She is also a certified Lean Six Sigma Green Belt. She is a graduate of UCall New Zealand. Such a great and dynamic personality is dear ma'am, Ms. Thanksm Gomez, President Clinical Services, Arahan Health Services, who will be delivering how 2020 flipped the nursing education. We are honored to have you, ma'am, on delivering the thoughts to all the nursing families. Welcome you, ma'am, and you can leave the platform.
Thank you, Sam. Thank you very much. And hello to everyone. I can only see Sam on the screen. So I'm hoping there are many people watching me. So hello. I'm always excited to meet nurses and especially nursing students. So now in that, Sam's introduction, a little bit of correction. One is that now I'm not with Arohan Healthcare Services. I have started my own company in July 2020, So a lot of things happened in 2020. So I'm the founder CEO of Signia Healthcare. So that's my company. So that's little correction. So I'm following Miss Susan Edamala, who has already dealt with in depth about the e-learning modalities, starting from different methodologies, including high fidelity simulation labs. So that was well dealt with the subject, and fortunately that's why I made sure that I'm listening to her so that I'm not repeating the same things. So mine is more about sharing my own experience of 2020, what happened during the lockdown, and hopefully that should throw some more light for all students, practicing nurses, and also faculties. So let me just pull up my presentation and see that everything works okay. Sam, can you confirm to me if you can see the screen?
No, ma'am.
Hello?
No, ma'am.
Can
No,
someone confirm? Can you see the presentation?
No, ma'am.
You're not able to see?
Yeah.
I shared the screen already. Your entire screen. Okay, 1 second. Okay, I know where.
Ma'am, you have to share the presentation and then click on the share button.
Okay, application window. Okay, got it. So it's slightly different from the Zoom.
Yes.
Okay.
Now I think
Now you can see, right?
Yes, ma'am.
Are you seeing one screen or two screens?
Just one screen.
One screen.
We can see the full screen of your presentation. It's perfect.
Oh, okay, fantastic. That's great. All right. So let me say, first of all, a very big thank you to Subharti University and PANNA DHAI Ma Subharti Nursing College, Dr. Geeta, for inviting me to this session. I'm very, very excited to be talking to nurses at any point of time. And you see there that is Signia Healthcare is my company. So let me see, how does that move? Yeah, great. So that's my company. Okay. So what am I going to talk? How 2020 flipped the nursing education. So now for all of you, just to know that why am I talking about education? Well, I am a very passionate trainer, and I think I learned long time ago that as a nurse, you are always an educator. So I was always, learning and teaching. And there is another saying that goes, when you learn once. And when you teach, you learn twice. And that has been my endeavor, that, I should be teaching so that I become a better learner. And that has been my life. And from 2012, I have stepped into total training and education, including the simulation. So that's where my passion lies, and anything to do with nursing to get better is very close to my heart, right? So what happens in 20 minutes? So I am hoping that's what the time Geeta had given me. So I made sure that I should be able to complete in 20 minutes time. So we are going to discuss my experience of training in lockdown, understand what methodologies can work, what is the need of the hour. So this is purely from my own experience, and yes, all the things that is required to be discussed and learned was already deliberated by Susan, and that was in-depth deliberated. So I hope that what I'm going to share is going to reiterate a lot of points and probably throw some more light into the current problems that we have in India, and how we can overcome. So I have been in this lockdown time in the digital world. So that's what I'm going to showcase. So first of all, this three words: acceleration, change, and paralysis. So this talks about any kind of changes that happens in the world at a global level. How does things happen? Either due to war, or there is a revolution, or of course there is a pandemic. That's where things change at a largest scale across the world. And this is what we have seen from COVID in 2020. So these three words is actually documented in the literature. This is what happens when something as large a crisis or catastrophe like this happens. This is what happens. So I'll be also discussing about my own experience in these three terms, and I will go the other way around to say that, mine was more about paralysis, change, and then acceleration. This the other way around, and that's how things do happen. So let's look at some changes that happen. So I looked at the Indian Nursing Council's website, and if you looked at this website last year January, you will probably not see these things. Now you can see the word virtual, webinars, e-learning. Now all these terminologies have kind of become, very common for almost all nurses. Now, last year in, let's say before March, I had been in training, okay, and 98, almost 100% of my trainings were all in person. That means people were either coming to me or I was going to the people. And who are these people? The nurses, sometimes the doctors, the paramedics, the front office, based on what kind of a program that I was doing, I was actually going to people or they were coming to me. Even when I met nursing students, they were in person. So we will travel for hours to be in some place. I'll be traveling by plane to be in one particular training venue, and conferences were held. We were traveling. So we actually had a lot of challenges to be in a particular place. And it took time. It took months before, we could even plan anything like that. So we have already started the change. So I looked at, a query I put, what happened because of COVID. So I brought this slide here because I saw the word NEET. So NEET is actually a entrance exam in India, right? So when I saw the word NEET, I said, okay, let me see what is this. So now this is the shorter form of not in education, N for not, E for education, not in education, not in employment or training. Very interesting word. And if you look at this particular thing over here, let me just get my laser pointer. Okay. 89% of the world's student population, they were out of school due to COVID-19 closures. And I think this happened with all the nursing students as well, because I'm aware of it, because I do keep in touch with academic heads and other nursing heads in the country. And I am the president of Association of Nurse Executives India, and I'm founder president. So I am in touch with a lot of senior nurses in the country. So there were discussions, our students had to be sent back home. Then there was this dilemma: should we call them back for COVID duty? Should we not call them back for COVID duties? I understand all those were concerned, how the syllabus will get continued, how will we finish all our clinicals. I had multiple calls where they said, ma'am, any idea that how can we assess the clinical skills through any other format rather than calling them to the lab and me being there. So there was definitely a paralysis that happened across healthcare, especially in the education sector. So 267 million are the people who are classified as NEET. NEET means they are not in education, employment, or training. And that's the impact that had on COVID-19. And I'm sure nursing education was also not spared. But it cannot stay like that forever. So I looked for some studies to see that, is there any, I'm sure that once the COVID came and a lot of things started happening, I'm sure the people who are in research, they were interested to know what will happen, as Susan told, even before COVID, there was some form of, technology being used for in the education sector, but not as impactful. And obviously, clinical or the patient touch is very important. So I personally feel, this is my own opinion, and I agree with Susan that, once a nurse is getting trained to be actually looking after real patients, somewhere along the line they have to have real touch with real patients. But high fidelity simulation centers or labs are extremely useful if they are designed and executed well. I know of a high fidelity simulation center in the country, and I have visited that. And I know that when I was interacting with the faculty over there, it was very evident that they were not fully aware that how much of creativity needs to go in when you are actually designing the delivery of a simulation lesson or a session. So let's see, what does this particular study say. So they found that there was unequal access to online distance learning. So I remember that some of the concerns raised by the faculty or by students is that I do not have connectivity. And we were, we never knew that we will all have to sit at home and have internet all the time. And I know I also have to have backup to make sure that if one doesn't work, the other one works, so that my session will go uninterrupted. So this was a problem for the nursing education because they were not prepared to learn from home. Obviously, there was disruption of the academic calendar. This I am talking now the academicians' language. So the calendar was prepared, that was totally disrupted. Cancellation of clinical placements happened. Yes, the students were not going to hospital, and some of them were called back much later and they were put on clinicals. Now, there was this question, should we expose the students to that kind of a risk or not? But personally, I feel they are getting trained to be a nurse or a doctor. So anyway, their life is going to be at risk. They are going to get back to healthcare if they want to continue to be in the healthcare. So nevertheless, once the COVID came, there was cancellation of clinical placements. There was teaching and learning gap, like the question that Sam asked now, that, when we teach, the outcomes are not exactly as we planned. So I think even before COVID also, this teaching and learning gap did exist because I was the recipient of the products of different colleges and schools, because I used to interview nurses. So my personal experience is that we are not actually preparing our students to be patient ready or clinical ready. So they learned a lot of theory, but then very difficult for them to translate that knowledge into real life scenario. So I think that is where the gap, I would say, existed even before COVID. Now, after COVID, obviously, I have not interacted or interviewed anyone, so I can't say that whether that got worse or not. But it is before that, I would say, if I interview 10 fresh nurses, probably I'll be very happy with one. I'll be kind of okay with 3 nurses, and maybe the rest are, they will have a lot of gap that they need to bridge before they become, really useful at the bedside of a private hospital. My experience all has been in private sector, so I cannot talk about government sector. So that gap existed and that gap still exists. But can we bridge that gap? Inability to conduct proper clinical assessment. This was the problem during the COVID, and it is the same for, I'm sure, in India also. We're not able to do any clinical assessments because everybody was at their home. And lack of facilities for online learning. Yes, because sometimes it's the mobile that they are using, and the mobile may not be possible to do their homework and submit, so not everybody had laptops. So those, and this one is actually from Sri Lanka, a country that is very close in economy and culture, etc., to India. So I can imagine we will have similar problem, right? Disruptions towards professional development. This overall for nursing, it was the same. But in my story, that is different. So I'm going to discuss about that in a while. Standard operational procedures were lacking because we're not prepared to have a completely, online or virtual kind of education or training. So we did not have any protocols or SOPs to manage that. Otherwise, we had everything in class, right? So I think this was a perfect, I looked at many papers and I found this very relevant. So I took that, and these were the points from that particular paper, right? So what happened in March 20 is a question to be asked, right? So what happened? So this, from here onwards, I'm going to discuss my own experience, okay? So as I told you, paralysis, acceleration, change, paralysis, change, acceleration, but paralysis definitely was the case, because March 24, lockdown. So all the trainings that we were doing, we had planned, everything came to a standstill. So that time I was with my previous company. And yes, the question, what will happen to all the trainings that are planned? No idea. What will happen to the business that we have planned? No idea. So there was definitely a paralysis for a very short time. We didn't know which way that we are supposed to go, These three circles which are here, this is a this is a slide, the picture I have taken from one of the recent trainings that I have conducted for a group of faculty from nursing college down south. So they wanted me to do a 12-hour session on accelerated innovative methodologies of training. So in that, this slide was used, especially when you are doing a remote, and I think even in person also, because we are dealing with young people, but they are also adults. So we just have to change our methodologies, andragogy, pedagogy. We need to. So I like the word conductor. That means the trainer or the teacher is the person who is facilitating, the catalyst, the coach who is helping the group of people to learn things and then transfer that learning to real life. And because that real life actually is a life of life and death. So that's a very important role that we are actually grooming people. And that has to be done with equal seriousness. That is very, very important. Okay. So learning innovation. So I had been thinking about this, doing about this from 2012, but it was more about in class. I was thinking how innovative can we be, how experiential we can make it, and I think I was hugely successful. Now suddenly March 20, I was forced to think that you cannot be with people cannot come to you, but you still would like to train. How will you like to train? So I had to quickly grow, transfer, and maintain. So it was very important that suddenly I have to change. I have to change what I'm thinking, and whatever that I was doing in person, now I have to do it online. So let me tell you my story. So March is the time we got the lockdown. So we started with our webinars and free learning sessions in April. And April itself, we started having online training sessions. We started with some leadership courses, which I started. And then I really had to spend time to see that in the virtual world, how do I engage with my learners? Because when people are in front of you, so it becomes far more easier to see the face, see the expression. And I think Susan mentioned that, that face, that interaction, that the eye-to-eye contact and the expressions are very important for you. Right now, I'm not seeing anyone. I'm just looking at the presentation, not a single face here. In Zoom, sometimes you're able to see some faces, at least. In my class, definitely I'll have, few faces. I'll tell them, please keep yourself on the video so that I feel that, I'm in front of really, really people. It took me a while, but now I'm getting comfortable. That even if I don't see, I know that there are people out there, and I'm expecting Sam to tell me in case there is any problem with my presentation or my audio or video. So you just need someone to help you. I think this is something that Susan has very nicely, listed it down. What are the things that is required when you actually get into e-learning? Okay. So for me, the challenge remained the same, that I have to explain not only the what, I have to also explain the how and the why of it. And I think this is what the last question, what Susan explained was that, the challenge is actually transferring what the trainers or the faculty they know to the students, and then they should be able to use that multiple in knowledge that they have, bring it to one scenario and make the right decision at the right time for the patient. It's very, very important. So I would say that is, whole lot of knowledge that we carry, and then we should be able to bring it back, and very logically and very practically we should be able to make decisions at the right time. So the methodologies in the e-learning environment, what worked? So that's what I realized, that I have to flip my classroom. I have to flip my classroom. So what happened was that in the current scenario, when I do the sessions, I feel that I'm actually giving more than what I was doing in the in-person classes, because I flip the model. So that means I give the material ahead of time. Tell them that now you whatever you need to remember or understand, do that. I think of giving online pre-assessment, so that they can. I think of giving them pre-reflection, so I give them some questions to think about it. So actually I am exciting their right and left brain far more than when they come inside the class. So usually I plan for the classroom sessions, and I expect everyone to come, and then we do the classes and we take it from there. But here, as Susan told, there's a lot of planning that goes on to see how can I make it far more engaging. So obviously, based on what kind of a solution that you use, at least I know Zoom very well. So Zoom gives a lot of possibility of using the chat and the poll and the breakout rooms. There are different activities, but a whole lot of activities is actually going outside the classroom, outside the classroom. And when they actually come in the classroom, we are actually trying to help them to apply, to analyze, evaluate, and then create. I think if you keep that in mind, especially for the teachers and the trainers, to think about it, how can I flip now? Today I'm doing a class on nursing audits and quality risk management. So it's a every week class. So today when they come there, I have already given them pre-read, and then I know that my class is designed in such a manner that the group is going to actually work on the 5 eyes and the fishbone or the Ishikawa model. I can teach any amount of theory on that. That's not required, because they're all practicing nurses, so they can read the theory. It's no point. We have to learn to apply. So let me tell you, when I interview someone, so let's say that I'm interviewing a fresh nurse, I like to tell stories. That way everybody understands what am I trying to tell. So I'm interviewing a nurse, and I ask her, okay, do you know what is myocardial infarction? This is real story. Okay, so she says, yes ma'am. So I say, tell me what it is. So she'll say the myocardial infarction is the injury or death of the myocardial tissue because there is a block in one of the coronary arteries. I said, oh, I'm very impressed. I said, wow, how many arteries are there, my dear? 3, ma'am. She knows all the names also. I said, okay, good. So let's see that, you are working in an emergency room. So this 40-year-old male is brought by his family and says that, he started with chest pain while he was shaving. While he was shaving, he started with chest pain. And so he's little sweaty. So he's brought. So what are you going to do now? Now that question totally was answered wrong. The person was lost. She had no idea. She knew what is MI, but she could not relate that information to the learned signs and symptoms to say that this particular person, 42, she just could not go a stepwise manner that how do I take a admission who is coming in with chest pain and is sweating. So high probability. So you have to call back on so much information that you are learning. I'm talking to the students, every time. Let me give you a tip. Every time, just start asking why for everything. Make your teacher's life miserable by asking why this medicine, why this answer, why this patient is like this, why it is so. Every time try to get an answer to your why. This is very, very important. So now mine is just a 20 minutes session. Even I know that, if you ask why to me, I can stay here for hours and explain lot of things. So the challenge now in this scenario is to get more in less time, because we also know that when you're doing an online session, your attention span is even lesser than that was before, because the people are not in front of you. It's very easy for people who are bored to say that my connectivity is very poor, or I can't hear, so I am off the video. I've had experience like that. People are not on the video, and then suddenly I call out the name and you don't find the person there. And when they come and put the video on, you might hear the mixie running or the washing machine running or something like that. So that means they have put it on and they are doing their own work. So having their complete attendance in the class is a challenge when it's a virtual thing. So now with connectivity having a problem, so it is very difficult to have everybody on the video. Though when I'm doing the session, I do ask them that please stay on the video as long as you can, so that I can see the people. I like to comment on their expressions. When I see their face, I'm able to say, oh, I think you have a question. Your face is full of question. Tell me what's your question. So there is some interaction, some laughter, some smile happening. So people are all engaged in the classroom. So what is happening? This is the flipped classroom. So usually before the participants are, uh, prepared to participate in class activities. So you are actually, sorry, this is not before the flipped. This is the entire model is the flipped classroom. That means when you are preparing for a flipped, a teacher has to think of what are the before activities that I can give, and what are the during activities that I'm going to give, and what is the after activity. So let me tell you, I was doing a session for a group of young leaders from a group hospital. We were talking about communication tools. So one of the tool is Teachback. Okay. So we had a discussion around Teachback. We had a little demo on that. Then now I've given them homework to go and speak to one patient who is discharged today, to go and ask the patient, teach back what you have been taught by your nurse, because he's going home, he or she is going home. So the nurse should have given the discharge teaching. So ask the patient to teach back, because that's one communication method which is finally confirming the patient has learned how to look after himself at home, right? So now they are doing that activity. Why am I making them do that activity? Not to check what their hospital is doing. That's not my prerogative. I want them to learn, to say that you can learn a lot of tools in the class. That's not a problem. But if it is not being used, you don't get the result. You have another communication tool called ISBAT. These are all the things which are being practiced in the services. And this is something that I would urge all the, college faculties to have, discussion with their counterpart in hospital and see what is the best practices. And, dovetail those things into your session so that they are already aware of it. And I had been in this game from 2012, and I know that, despite the fact that every session, every leadership class, every nursing session that I do, communication is definitely given a lot of importance. And I actually talk about different tools, and we do role play. Can you do role play virtual? Yes, you can do role play virtuals. I did leadership course for a third year final year nursing students from one college. So they went recorded videos and they sent, because that was their assignments, to say you learned the communication tool, now can you record? And they were so innovative that people were in different places, that they actually recorded and edited the video and they presented one. That means today's generation is far more tech savvy than the older generation. We have to tap that strength that they have and use them, because they can be the moderator or the facilitator of their own learning. So you have to allow them to explore, and then check their understanding and extend their learning. So they actually learn more. So my experience had been that, actually in my sessions, there are more things happening than it was happening before, because I am paying more attention before and after what can be planned more. Now, looking at this entire, I mean, this is not the uh, Indian one, but the global corporate learning. I mean, it's not a education sector. That means even the hospitals and all the kind of all industries where learning is going to happen. The learning management system. This is actually e-learning (LMS). It is going to grow by over 25 percentage. That's the growth. So even business wise, while we are speaking, there are thousands and thousands of company coming to designing for products and solutions. So today what we are using, it's a new one that I'm seeing, is another technology that we are using so that I can speak to so many of you at the same time. And if this was not the case, I would be telling Dr. Geeta, I have to check. That means I will have to spend at least 4 hours extra just to give this 20 minutes of session. That means 2 hours traveling to your university and then coming back from Gurgaon. So the virtual environment allowed me to think of it and say, yes, within one day also I can agree to a session, because it does not take me much time, because I don't need to move from my home, right? So let me talk about the impact on nurses learning with Signia Healthcare. So one impact, definitely unequal access for me became more equal. I learned that, now I have access to, college students, I have access to college faculty. I have, so in my classes, a lot of leaders started to come, because they didn't have to take leave. They didn't have to move around. It was okay to come at 7 p.m. and learn after they finished their session. They found it comfortable because it's only 2 hours. So they invested 6 days, 2 hours is not very difficult. And online testing was happening. The assignments were being presented through WhatsApp or through email. Sometimes it is the Google form or Google Excel sheet. All kinds of tools were used based on what kind of a topic it was. So for me, it actually became more accessible, and I found that one good thing that happened was that people who were not aware of much of technology, they became more aware, because there was no option left, because we were all locked down. We were not able to go out. So we learned banking. We started paying by Paytms and Google Pay, etc. Before that, if you tell 200 people, half of them will say, I don't use this, I don't use that. But today's state, many more have learned not to have any hard cash, and you can do those as transactions. Disruption in academic calendar, my disruption came down, because we discussed and we made sure that we fix a time that is suitable for the client. And it didn't matter where the students were sitting. They could be from 10 different cities in the country. They could be coming at the same time if they agree with that particular time. And groups, those who had groups of hospitals, they were able to get in 5, 6, 7, 8 hospitals, different students into one program, so that I can do that particular program. And I'm sure that even the nursing heads found it, that disruption was more happening, because virtual means anytime, anywhere kind of meeting can happen. So that kind of increased for the people who are in the services. I know that that's a challenge for them to manage. Cancellation of clinical placements. Well, this still remains a little bit of a challenge for me, that in case if I am, let's say that I am teaching, I'm a critical care nurse, so I teach critical care nursing as well. So I'm teaching hemodynamic monitoring. I'm teaching adult mechanical ventilation. So I make it as much interactive as possible, and the questions are more scenario based. They are not rote learning. Some of them are rote learning, because that's something that nobody can do anything about it. You have to remember what is normal CVP before you decide, I can identify a abnormal CVC. So that is something that you have to rote learn. But after that, when you get a scenario, you are supposed to decide. So what I do is I try to now, because they are all practicing nurses, so I actually tell them to go and find. So if I teach them, let's say I will teach them capnography, and I'll tell them, go to your ICU, look at your ventilator and take the photo of your capnography, talk to the doctor, find out what is abnormal. And tomorrow when you come, let's discuss that. So that is how I try to bridge the gap of clinical experience, I should say. Somebody else was calling me for a critical care training. So I said, I'm sorry, I don't travel, but I can definitely take your, nurses through this program and they will definitely earn. But on the other side, I would need an excellent educator who can kind of be the spoke to ensure that the assignments and the on job learning is happening the way it is designed to happen. Then the results can be better. That's how I can bridge the gap between the teaching and application. I would not say learning. They usually learn in the class, that's not a problem, but application of the learning. So for me, that is very, very important when I'm doing that. Now, clinical assessments in my classroom, it may not be easy, but where possible, I use some solutions which are available freely on the internet to simulate some things in the class itself, so they are able to do that. Or I can give them videos before, and that's something I use. I sent videos before. I ask them, look at the video and share your reflections in the WhatsApp itself. So it kind of reduces the time of discussion and the flow of discussions is understood by me, and I plan that tomorrow I need to now discuss these things because there was some misunderstanding, there was something, so I can clarify those things. Yes, questions can be also shared in advance after you learn an article. So one way of getting more engagement is send an article, ask your students, make questions, let them make three questions and they can ask each other, or you can use many other technology assisted solutions are available that you can use in a virtual world. So we don't have that kind of a time. So lack of facilities for online learning, well, it is getting better. Most of my students, they still come on the mobile. So if they have to do work on Excel, some of the programs are high end and they have to do some work on Excel. So I tell them that when you get back to hospital, make sure that you have an access to Excel, do the assignment and send back to me. Okay. So that is still there. Disruption towards professional development. Definitely there was disruption, but it was a positive disruption. So today, after the COVID has set in, I think from July onwards, on a regular basis, I train minimum 30 to about 60, sometimes 100 nurses on leadership course alone. So for me, that is a professional development facilitation. So a lot of nursing heads have attended my session. Why? Because this is virtual. Otherwise, when I'm doing a program in Delhi, I will get a call from Mumbai, ma'am, when are you coming to Mumbai? Now, no more such calls because everybody can come on the platform and learn. So that disruption was very good. Now, standard operational procedures, yes, there has to be certain discipline in the way that I am functioning because there is registration, there is payment, there is pre-work, there is student guide, then the presentation, then the assessments during the class, after the class, and the closure and the certification, all those things are there. So I have to have my own SOPs. So when you're also planning some things, so usually I am a great fan of Excel. So I use Excels to make sure that I have the right checklist so that I don't miss anything. After some time, I don't even have to refer to the Excel, but it kind of helps. Every time I have, cues on my board which says that this is pending with this batch and that batch, etc. So you need those kind of things happening in your, in your planning sessions also. So this is required. And today, so now, what is the need of the hour? We are already exposed to the paralysis. We finished with that, and the changes are happening. Now we need to accelerate, maintain, sustain. So there are challenges. So nursing is about having an experiential learning. I always used to tell this, teaching nurses what they have learned in college again and again does not make them a better nurse. It has to be an experiential learning, and experiential learning can be designed in many different ways based on the level of the learner. So by and large, if we are, as I told you earlier, Concentrate on the why. What and how is important, but why is the most important. If I understand the why, then I will probably do it the right way. So it's very important to go through these sessions. This is your experiential learning to say that, what happened? What did I experience? Why did that happen? What do I do next? So when you look at a patient, it is very important that within couple of, sometimes it is seconds, sometimes it is minutes, that you have to decide, should I call a doctor, should I not call a doctor, do I need to do something immediately, what is the challenge in front of me? So it's a huge responsibility. Susan asked the same question, that if you are just asked to inform the doctor, then we don't need to spend 4 hours 4 years learning that. For everything the answer is going to be, I will call the doctor. Then that can be done by even an attendant. So why do we learn for 4 years? So I ask my nurses, if you don't know the medicine, why are you giving it? Patients, they take their medicines themselves. They may know what are my medicines. Attendants will give medicine to the patient without knowing much about the medication. Then what's the difference between a patient attendant and a nurse? The nurse becomes different because she knows the medicine, the actions, the side effects, what she should watch for, what she should do before and after and during. She is good in patient education. I'm just taking one example. So those challenges are still remaining. So we have to find solutions. And it is possible to discuss these, under the gamut of making our nurses perpetual learners. And that's what Florence Nightingale had told, that, let's never consider ourselves finished nurses. We must be learning all of our lives. And me, I am now 62 years old, and I will say I still continue to learn. I don't think I can ever say I'm there, I've done it, that's it. No, I have lived and experienced more years than most of you. And many of you were not even born when I became a nurse. But I know I had been learning continuously, and I always ask why. This is something that my my teachers told me, that always ask why. So when I was in hospital, when I was a young nurse, usually my team, especially the doctors, will run away when they see me. They'll say, "Oh my God, Thanksm is on duty." Oh, she'll ask 20 questions. So whatever orders they write, I'll say, "Why did you order this one? Oh, you think you ordered this because of that?" Because for me, that is an opportunity for me to learn about that patient. Because serum potassium can be ordered not only for one reason, it can be for many reasons based on the patient's diagnosis. That's how your clinical judgment starts to improve. But your foundation of critical thinking and clinical judgment has to be so sound that you are able to ask the why, connect the different cues that you are getting from the patient, make a decision very quickly, and act upon it. I mean, that is what is nursing. So that's a challenge in the virtual world, but I feel it is definitely possible, provided that we are able to think the principles of flipped classroom more creatively and more innovatively. And it is out there. And only if we challenge ourselves and come out with new techniques, then we can recalibrate. Once, so in the last 6 months, from July, am I doing the same things as I started when I started in July? No, I have modified many things because I experienced and I learned, oh, this is not a great way of doing things, let me do this. And sometimes I challenge myself, I said, let me take the risk of doing this in the virtual. I used to do that in the classroom. Why should I hesitate? Let me try it here. So we tried, and then it worked. So that is how it gives you positive energy to say, I can do new things. And the students can also be excited to be a nurse. Only when you are so confident, you love being a nurse. So that's where the quote comes, that if you love something that you do, then you are not calling it a job anymore. And I wish that all of you will find your ways in such a manner that you love doing what you're doing, you are passionate about what you're doing, so that it is not a burden anymore for being a nursing faculty or a nursing student or as nurses. So with that, I will say a very big thank you and say thank you so much for listening to me. And I'm going to stop sharing my slides now. And Yes, I'm back on the video, so that's good. So I hope maybe I exceeded a few minutes extra, Sam. Thank you very much for that time.
Yes, ma'am. Actually, your experience during this lockdown time, you shared with us, it is an inspiration for us that how the nursing faculties and nursing students, how we should overcome during this time. So it was an excellent and thought-provoking and nice speech that you have given to us, and we learn more things, ma'am. So we are so
Questions?
yeah, and I want two more questions as well, ma'am.
Yeah.
Actually, how flipped classroom enhance the academic performance as well as the classroom engagement among nursing students?
The if you are able to plan very well, flipped classroom, one of the most important thing is the planning. You have to first, Susan mentioned to this, first of all, whatever intervention, what are your objectives? Because for the same session, you can have 10 different objectives. So it's very important. That's a very basic principle of being a trainer, is also to first write down what are my objectives so that you don't get wandered. High fidelity simulation is same, because in one scenario, you can have 10 objectives. So write down your objectives first and see that what are all the things that you can give prior to the students coming to the class. So you might find an article, or you may find or even your own video. For example, my this 25 minutes video, I can record it myself and make sure. One of my experience, because one of the assignments that I gave when I trained faculties was to give me 30 minutes of their videos by using the innovative technologies, methodologies. So I still find, there's a bit of a stiffness in, when you are giving a, video recording. Relax your body, and you just think that your students are in front of you. Use your hands, have a relaxed body language, and make your video maybe 10 minutes, 12 minutes. So then give it to them, said to reflect, write reflections, make questions, or ask questions. You can give all that activity, and next day when you come, you get straight into that. And you can break them out into virtual breakout rooms to come together, discuss, and then come back and present. So you will design the before, during the class, then after the class. So before, during, and after should be planned very well. Unless and until you do this repeatedly, now you cannot become creative just like that. When you have been practicing for many years, then you will learn that it's like, 1 minute I can immediately change and come up with something else. But you have to force yourself to have that experience. So day in and day out, you should be. The flipped classroom is a totally, completely different domain. I actually bought a book and I told them that, I will come back to you for a workshop on flipped classroom, because that itself is a methodology that people are using abroad, even before COVID also. That understanding was there. But now in nursing, because of COVID, we are forced to think about those principles. And it's not very far away from all the things that Susan discussed, or I discussed. But yes, there is a certain science behind that flipped classroom. I'm only touching a bit of it. Planning and executing before, during, and after, I would tell that as a best way to approach. So otherwise everybody thinks, flipped classroom is so easy. COVID came, so I will make it e-learning. It's not completely that. It's a lot of things will go in, and there is a lot of work that nursing faculties need to do so that you can standardize the content. So you can remove the variations between a very creative teacher and not so creative teacher by standardizing the content. And that's what happens in high fidelity simulation labs also. All the scenarios are pre-written, objectives are written, the flow is written, and then you are only observing how they are going. So it is similar to OSCE. When you do OSCE also, it needs to be standardized. Otherwise, if it's not standardized, Sam will give A+ to somebody and I may give C to somebody based on my understanding. So you have to remove that bias from there, right? Yeah.
Okay, ma'am. So the next question also is, I got answer for the next two questions also.
Okay.
So it's thank you so much, ma'am, for your time you have spent along with us. It's our pleasure, ma'am. Thank you so much, ma'am.
Thank you very much. It was very nice to be with all of you, and special thanks to Dr. Geeta. And wish you all the very best, all the nursing faculty, nursing students, Panna
Daima.
Panna Dhaima, Subharti Nursing College. And I was thinking of visiting your college. We had been talking about it. Now, at least virtually, I'm able to be with all of you. Thank you very much. Thanks a ton. And wish you all the very best to all of you. And if I can be of any service to any one of you, do let me know. Dr. Geeta knows where to find me, and Sam also knows. Yeah.
Okay, ma'am.
Okay. Thank you.
Thank you,
Bye
ma'am.
bye.
Bye-bye.
I'll take leave now. Thank you.
Yes, ma'am.
Bye-bye.
Yes, ma'am. Okay, bye bye. It's nice session we had with Susan Edamala ma'am and Ms. Thanksm Gomez ma'am. It's our pleasure to have both of them. They have spent such a valuable time with us as they were busy also. So it's a heartfelt thanks to both of them. Now we have a session regarding our audiovisual aids that helps this situation, how we can use it. So how the past AV is being used, present, and what will be the future of AVAs. So you can say as augmented reality. So here we come, our students, MSc first year students, they joined together and they found a solution for this. What was the past and present and the future AVAs?
Good evening, everybody. Myself, Mrs. Shaheen Akhtar Khan, Associate Professor, Department of Community Health Nursing, feel privileged to bring into your vision the current and future teaching learning modes. The future scenario swims deep into augmented reality. The future generation gonna rise significantly in the years to come in almost all walks of life. This is a simple love story of art, meeting technology and creating magic. The magic will get us into a completely different yet fascinating world. Creativity along with imagination, these are two important skills that boost augmented reality of today's scientific era. Augmented reality is one of the most promising digital healthcare technology and has the potential to change the healthcare in the days to come. During different eras of teaching and learning, including today's scientific era too, chalkboard is the basic and constant mode of teaching and learning. During the past 20 years, there has been a transition from the basic to the most advanced mode of teaching and learning. So here, I introduce the PG students of PANNA Subharti Nursing College who will take you to the journey of transition. So here we move.
Good evening, good morning, everyone. So we are standing in the older era of AV8s that we have used chalkboard and chalkboard, green board, white board, where we have started our AV8s, which is the best method we have ever used, and now also we are using the same. Starting from the rollerboard, we have moved to the maps or pictorial representation like that. Maps we have used, and we have moved to the puppet show, which we mostly used in the community area to represent the disease conditions and all. We have used the puppet show. And moving further to the projected aids, we have a slide projector in which we used to keep the slides in front of the screen and it will be projected in a wall. Then we have changed that into the TV. we have changed that into the TV or VCD player, where video recorders will be there and things will be projected on the TV, and that is also another audio visual aid we have used further. And from the slide projector, we have just moved further to the OHP projector, otherwise overhead projector, in which we used some transparent sheets like this, and we are writing the teaching materials inside this with a permanent marker or temporary markers, and we'll be keeping on the slide projector, and which will be also projected on a screen. And then, like that, several types of previous models we have used, and from there we have moved to the various pictorial methods, or to a middle era where we have used both the things, that is both the several types of AV8s, like non-projected and projected AV8s have changed the era into a medieval rate, and that will be explained by Ria.
So here we have a picture. In picture, we just show the causes, the symptoms, and the treatment of the diseases. Next, we have a flip chart. Flip chart consists of pad sheets in which we just stuck in, and it concludes all the subheadings of the specific topic. Moving further, we have a leaflet. Leaflet, we just take a sheet of paper and then we just write a topic of it. Like I have shown here the mechanism of flavor. Next, we have a bulletin board. It is mainly for the public message. Next, pamphlet. Pamphlet is used by in a teaching, as it just be folded in 3 to 4 and just given to the student to have a great idea of it. Moving further, we have a cartoon and a comic. This represents to give, this is used to represent the main topic and just give some idea to the students. Next, we have a tree chart. As it is shown, the tree have a branches. So we have a specific topic, and from that, they divided in a subheadings. Like we have used method of data collection, and it is divided in mainly 5 parts. So we have shown it here. Next, we have a pie chart. Pie chart represent in a percentage, as it is shown the uses of Google. Next, we have a line graph. It is also a comparative in which we have 2 points, and here we have shown a blood glucose levels vary between the type of a food eaten. It shows the elevation as well as the lower limits of the points we have taken. Next, we have a column graph. In column graph, it is represented in a bar graph, and it is also a comparative between the days, or we can take a countries, continents, etc. Next, we have a diagram. This represents anything which may be a disease, which may be a stages. It can be represented in anything. A pictorial graph. Pictorial graph is represented in a picture, icons, different emotions. Like here we have used emojis. Thank you.
From there, we are moving to somewhat to the specimens. Specimens means where we are giving some more clarifications to students by giving them an original view of the organs or original view of the body parts, so that they can be more clear about the body parts and also the disease conditions, what is happening to a particular human body. So the specimens are also one of the medieval parts in which we are using as an AV8, because they are giving some more clarifications than any other types of charts or any types of models what we have used. From there, we are moving to the models. So simple models are there. First it has come to the notice in the form of simple models in which we are explaining all. For example, if the structure of brain means the parts, they will be projected. The parts and what all the parts are there, that will be projected, and that will give a more specific idea to the students regarding the particular organ. From there, again, we have changed that simple model has changed to working model. It has changed to working model in which we can show the students how a particular organ is functioning, For example, we are giving a working model of a kidney, and if you want to show. So if you want to show that students how the kidney is working, that the working models are there, that it will show that how it will be going, and it will be filtering and coming back to the through the urinal output. That is the working models. The same thing, the working model of heart is there. Like that, so many working models have replaced the normal models, so that the students will get a specific clear idea about the organs and also the systems of human body. From there, again, we have moved somewhat advanced to the simulation. Simulation means normally in medical fields, they are going to the hospital and have a direct interact with the patient. So before going to that, we have to give them a practical based knowledge through the simulation mannequins. So mannequins has replaced the models. Actually, if you say that, the mannequins has replaced the models, and it is something like a working model, but it's not a working model. But still, they will give a student an idea regarding the patient, and also for what all procedures they are doing, they can do in the dummy or they can do in the simulation mannequin, and then they can go and practice the same. So that is the newest method what they have approached. This is the medieval era. From there, we have moved further into the newest technologies that has changed it into the normal, from the slide projector to it comes to the LCD projector, where there is no need of any types of model, there is no need of any working model, there is no need of any type of mannequins. You can go and show the students what are all things you need. If you want to show them the slides, what are the slides you can show them. If you want to show them videos, you can project the videos. If you want to show the procedures, you can show the procedures. So the technological advancement has changed a lot. From there, from the normal slide representation to the LCD projector, where the students can sit in a classroom and they can see what all things are happening in the hospital. Even they can see that also, and they have changed it into videos. Their procedures, you can show them as the video, so that they will get a clear ideas. So that is the present era, and from there, it is also this is also a newer era, but the technologies has moved further. It has moved further, and now it has come to virtual classrooms and also to the augmented reality.
So let's see how the augmented reality works. So by using some peculiar glass, you can you can select the organs which you want. So for example, I have selected the heart, so you can go into the heart, inside the heart, and you can see the valve and how the heart is pumping. And like that, you can select any other part of your human body from a list of structures of your body. And again, I'm going to select the skeletal system, so you can see the skeletal system we have selected, and you can separate each part or separate each nerves also, and you can go into the structure, you can see the internal structure. So now let us move to the another aspect of virtual reality. So you can see a skeletal system in front of me.
This is the virtual view of your skeletal system. So this is your skeletal system. This is the anterior view of your skeletal system. You can see your skull, you can see your thorax region, you can see your lower portions, lower extremities, and you can see in this lymphatic system, you can see, and also the circulatory system, you can see in this. So let me rotate it into the posterior. Let it go to the posterior view. See, this is the posterior view of your skeletal system. You can see the pelvis clearly here. And also the same things, the posterior part of your vertebral column, you can see, vertebral disc, you can see. So this is the posterior view. And you can see the side view. Let's just rotate it to the side, and you can see the extremities there. You can see the extremities, upper extremities, and also the lower extremities, you can see. So then again, rotate to the anterior view. So like this is the virtual. Now this is the newer technology what we are using, that keeping the objects near to you and teaching you people. Thank you.
Stop. And once again, no problem. Yeah. So, so Jasper, kindly reduce your volume. Jasper, kindly mute your. Reduce your volume. Jasper, kindly mute your. You join. Don't join. You come here. Okay. So still now we had about the airways, how it was in past, present, and future. Still now we had about the airways, how it was in past, present, and future. Still now we had about the airways, how it was in past, present, and future. Still now we had about the airways, how it was in past, present, and future. How it was in past, so now we are going to the next session, the scientific paper presentation session. So now we are going to the next session. Just remove everything. The scientific paper presentation session. Now we are going to the next session. Just remove. Scientific paper presentation. So now we are going to the next session on scientific paper presentation. We have 3 scientific paper presentation today. So the judges are Professor Hepsi, HOD, Department of MSN, Panadaima Subhati Nursing College, and Ms. Rajalakshmi. She's the JAPICO instructor. So they both are going to judge. So before that, I welcome all the participants and the presenter, those who are going to present. So, yeah, Jasper. So the first participant is the first presenter. Welcome, Rajalakshmi ma'am. Your mic is mute. Your mic is muted, Rajalakshmi ma'am. Okay.
Oh, thank you so much, sir.
So welcome to this session. As today only three paper presentation you'll be evaluating.
Okay,
Estimate
sir.
you will be
Okay.
evaluating. So now
Okay.
yeah, lot number, you can consider him as a lot number 1, Jasper. He will be presenting his session.
Okay, sir.
Paper. You go to
Yeah.
here. Just I'll share the PPT of Jasper.
Yeah.
This is it. It's not there. Send it. Yeah, we are sharing the slide for Jasper. Just hold on. Just close it. It's in the mail. Okay, hope Jasper, you can see the slide.
No, sir. Yes, sir. Yes, sir. I can see, sir.
Okay, so judges, Mr. Rajalakshmi and Professor Hepsimem, kindly notice
Yes, sir.
lot number one. He is going to start. Only 7 minutes the time for Jasper. Within 7 minutes,
Okay,
you can
sir.
conclude and you can answer to the
Okay, sir.
questions what they ask. Okay, you can
Okay,
start.
sir. Okay, sir. Good evening, ma'am. Good evening, sir.
Good evening,
Now
Jasper.
going to yes, ma'am. My statement of the problem is study to evaluate the effectiveness of music therapy on pre-procedural anxiety of clients undergoing coronary angioplasty in selected hospital, Coimbatore. The next slide is objectives. Next slide, sir.
Next slide.
The first objectives of my study is to assess the level of anxiety among clients undergoing coronary angioplasty in the experimental group and the control group. There are two groups. One is experimental group and the control group. First, I'm going to assess the level of anxiety among the clients undergoing the coronary angioplasty. Then my second objective is to evaluate the effectiveness of music therapy on anxiety among clients undergoing coronary angioplasty in only the experimental group. And my third objective is to find out the association between the pretest level of anxiety with the selected demographic variables undergoing the coronary angioplasty in experimental group and the control group. The next slide is next slide. Hypothesis. The first hypothesis, there will be a significant difference between the pre-test and post-test level of anxiety among clients undergoing coronary angioplasty in experimental group and the control group. The second hypothesis, there will be a significant difference in post-test level of anxiety among clients undergoing coronary angioplasty in only the experimental group. On the third objective, there will be a significant association between the pre-test level of anxiety among clients undergoing coronary angioplasty and the selected demographic variables in the experimental group and the control group. Next, the methodology. The research approach which I was selected for my study is the quantitative research approach. So next slide. Research approach, quantitative research approach. Under that, my research design is quasi-experimental, pre-test and post-test design. I use the research in my study. And if the target population is clients, those who are undergoing coronary angioplasty in Coimbatore, and the accessible population for my study is clients undergoing the coronary angioplasty in Sri Lakshmi Hospital in Coimbatore. Next slide, sir. The sampling technique which I adopted for my studies, purposive sampling technique. There are 60 clients. Under that, I split into two groups. First, one is experimental group and the control group. Both group contains 30 clients. For the experimental group, the demographic variables are age, gender, religion, educational status, occupation, marital status, type of family, source of financial support, and the history of previous surgery. In experimental group and the control group, the demographic variables are given, and the intervention is only given to the experimental group, and the routine care along with the nursing care is given to the control group. After the intervention, the post-test is conduct both the experimental group and the control group. The data which I collect by using the modified straight rate anxiety inventory to assess the level of anxiety. In post-test, I interpret the data by using the descriptive and the inferential statistics analysis, and the findings are reported in the thesis. The next slide, sir. The scores are interpreted as there are three categories. First one is mild anxiety, moderate anxiety, and the severe anxiety. The scores 40 to 80 belongs to the mild anxiety, and 81 to 120 is moderate anxiety, and scores 121 to 160 is the severe anxiety. Next slide, sir. This slide shows the data on frequency and percentage distribution of pre-test and post-test level of anxiety in clients undergoing coronary angioplasty in both the experimental group and the control group. In the slide shows in the pre-test, in experimental group, there are 56.66% having the severe anxiety, and only the 16.67% having the mild anxiety. And same in the post-test regarding the experimental group, there are no persons having the severe level of anxiety, and only the 76.67% having the mild anxiety. And in the control group regarding the pre-test, there are 40% of people, clients having the severe level of anxiety, and the remaining 60% of people having the moderate level of anxiety. And in the post-test regarding the control group, there are 66.67% having the moderate level of anxiety, and only the 33.33% having the severe level of anxiety. Next slide. In this slide, I shows the data on mean standard deviation, mean difference, and p-value of pre-test and post-test level of anxiety in both the experimental and the control group. In this slide, the pre-test mean is 108.23 and the standard deviation is 24.822. In the post-test regarding the experimental group, the mean value is 75.9 and the standard deviation is 7.275. The mean difference in the experimental group is 32.33 and the t-value calculated t-value is 6.768, which is more than the table value, which indicates it's significant at the proportion of 0.05 level, which shows the study is effective. And in the control group, the mean value is 119.4 and in the post-test 118.23 and the standard deviation is 12.60 in pre-test and 8.14 in post-test. The mean difference is 1.17 and the calculated t-value is 0.391, which is not significant at the level of 0.05, which shows the control group is not significant. Only the experimental group is significant at the level of 0.05 level. Next slide, sir. In this slide, data on mean, standard deviation, mean difference, and t-value of only the post-test level of anxiety among clients undergoing coronary angioplasty in both the experimental and the control group. In this slide, the mean value of experimental group is 75.9 and the standard deviation is 7.27 and the control group mean value is 118.23 and the standard deviation is 8.18. The mean difference is 42.33 and the calculated t-value is 24.83, which is also significant at the level of 0.05. It is higher than the table value, which shows the study is significant. It means the music therapy is reducing the level of anxiety of clients undergoing the coronary angioplasty at pre-procedure. Next slide, sir. In this slide shows the data on association between the pre-test level of anxiety and the selected demographic variables among the experimental and the control group. In this slide shows there was no association found between the pre-test level of anxiety with the selected demographic variables like gender, religion, occupational status, and the marital status. And there was a significant association found between the age, educational status, type of family, source of financial support, and the history of previous surgery, having the significant association with the select demographic variables. Next slide, sir. Conclusion: music therapy reduces the anxiety level by relaxing the body and mind. This indicates that music therapy is an important non-pharmacological method to reduce the anxiety level among clients undergoing coronary angioplasty. Hence, I conclude that the music therapy can be one of the methods to reduce the anxiety among clients undergoing coronary angioplasty in pre-procedure. Next slide. Limitation, data gathering and analysis, interpretation of data on a software tool such as SPSS was a big challenge in my study. And the recommendation which I found from my study is the study can be replicated with large number of samples, which would facilitate generalizations. And all staff nurses have to be trained to implement the music therapy as a non-pharmacological measure to reduce the level of anxiety among clients undergoing the coronary angioplasty. And the next one is a similar study can be conducted among the people with various preoperative surgical procedures. The last recommendation which I given is further research can be carried out to find out the effect of music therapy on other surgical procedures like CABG, pain of cancer patients in the pre-procedure, pre-op level. Thank you. Thank you, sir.
Okay, good job, Jasper.
Thank you, ma'am.
It's looking good. I would just
Yes.
want to know about your pretest tool,
Yes, ma'am.
modified sleep trainer anxiety. Do you want to just briefly explain it?
Yeah, yes, ma'am. In modified state rate anxiety inventory scale, there are 40 statements. The first
Yes.
25 statement is positive statement, and then further 20 statement is negative statements. And one second. No? In the categories, first one is not at all, and the second option is somewhat, and the third option is moderately so, and the fourth option is very much so. In this category, the score 1 is not at all, and the score 2 is somewhat, and moderately so is 3, and very much so is 4. And the
Okay.
another 20 statements negative statement, that is almost never, sometimes, often, or almost often. Yes.
Okay, Jasper. Can you explain me the third hypothesis of yours? Third
Third,
hypothesis, which is
yes,
between
ma'am.
the anxiety.
Yeah, significant association between the pretest level of anxiety among the clients
I-
undergoing
i-
coronary angioplasty.
Is there the association between the pre-test and anxiety or the post-test and the anxiety level?
Pre-test and the anxiety level.
Sure. Okay, Jasper. Thank you.
Thank you, ma'am.
Thank you.
Thank you.
Okay.
Thank you, sir.
Yeah. Thank you, Jasper. Thank you for your presentation. It's a nice presentation. Okay. Next, eventually. The next contestant, Vaishali Tambare, are you there? Vaishali, are you there? We are waiting for the next. Yes, yes. Hello, Vaishali, are you there? Yeah, okay.
Sir, am I audible?
Yeah, I'm audible.
Sir, is the screen visible? Yes, sir, I
Just
am
click.
there.
Yeah, just click your slide.
And screen, sir?
Yeah, screen visible, but we are not able to see your slides. Just No, you just open the applications, just open your slideshow, then you can share it. You just open your slides, make it a slideshow, and then come back, share the screen.
ये स्लाइड शेयर नहीं होता.
No, first you open your slide, make it as a slideshow. Then at the down, you'll have share screen. Yeah, now you share screen. Yeah, yeah. Yes, slideshow it.
Now it is visible, sir.
Visible, make it slideshow. Okay, fine. You can start,
Okay. Good afternoon, sir, and good afternoon to all judges. And thank you for giving me opportunity for presenting my abstract. And my abstract is to assess the effectiveness of new protocol on endotracheal tube suctioning among the ICU staff nurses, and I have taken this study during my fellowship in evidence-based nursing, and it was guided by my guide, Dr. Seema Singh. And endotracheal suctioning is the procedure used regularly in intensive care unit. Despite this, good evidence supporting its practice is limited. And
Vaishali, you can go with your statement of the problem. Just no need of introduction. You can go with your statement of the problem and your objectives,
okay.
hypothesis, methodology, and
My
discussion.
statement was to assess the effectiveness of endotracheal tube suctioning among the ICU staff nurses. And the okay. And the hypothesis was there will be significant improvement in the endotracheal suctioning skill and patient outcome after the implementation of the new protocol on endotracheal tube suctioning. Aim of this study was to is to assess the existing practice of the staff nurses regarding the endotracheal suctioning before implementation of the protocol, as well as to assess whether the protocol is effective or not. And the objective of the study to assess the existing practice of staff nurses regarding endotracheal suctioning, to assess the effectiveness of protocol on endotracheal suctioning, and find out the association between the selected demographic variable and knowledge of the nurses. The method was one group pre-test post-test design. The study was conducted in ICU of selected hospital. The population for the present study was ICU staff nurses, and the sample was the staff nurses from the selected hospital. Sample size 30 staff nurses, and the method was convenient sampling technique. And the percentage, the reason and the percentage wise distribution according to their age is 21 to 30 years 83%, at the age of 31 to 40 years 10%, and 41 to 50 years 6.7%. The percentage according to the gender 70% female and 30% male. And according to the educational level, the sample was.
Vaishali?
Yes, ma'am.
Vaishali, can you just skip all this and explain your interventions and the results?
The intervention provided was the endotracheal protocol regarding the endotracheal tube suctioning.
Hmm. Yeah, continue.
Okay, ma'am. The interventions for the study implemented was the endotracheal tube suctioning protocol, which is standardized protocol by the American Heart Association. Yes, and the when the practice scores was assessed, the pre-test score was 53 point, and the postage was 88%, which shows that the endotracheal practice score was improved after the implementation of the protocol. And there was a significant difference between the knowledge score in pre-test and the post-test. In the pre-test, the standard deviation was 1.74, and in post-test, it is the 1.21. So it shows that there is a significant difference between the pre-test and the post-test knowledge score was improved. And the significant difference between the practice score in the pre-test pre-test score was the standard deviation was 2.85 and the post-test 1.62. So it shows that the practice improve after the implementation of the uh, protocol on endotracheal tube suctioning. And there was no association between the demographic variables of the staff nurses. So I summarize that there is significant difference between the knowledge and practice course of ICU staff nurses before and after the implementation of the endotracheal tube suctioning protocol. And clinical implications, this study provided more insight regarding the protocol and endotracheal tube suctioning, and it can be implemented for the enhancing the skill regarding the endotracheal tube suctioning among the ICU staff nurses. And the study can be carried out with the large sample in different setting and the different methods of the suctioning. And this protocol on endotracheal tube suctioning will help the staff nurses to improve the knowledge and skill on endotracheal tube suction. Okay. Hello, ma'am. Ma'am, I have completed. And for this study, I have referred the done the review of literature and the around 73 studies I have referred.
Okay. Vaishali, can you just simply explain the design and approach of the study?
The design was one group pre-test, post-test design, ma'am.
Mm. What did you do during the pre-test? Just by curiosity, I'm asking, what did you test there?
Ma'am, actually, during my study, I have observed during pre-test. I made the checklist, and there was a knowledge
Mm.
questionnaire on the
Okay.
research. Yes, ma'am.
Yeah. Tell me.
First, I have assessed the knowledge, and there was a practice score checklist. So,
Mm.
based on that, I have assessed the knowledge and practice skill of the staff nurses before the implementation of the protocol. And after
Okay.
that, I have provided them with the protocol guidelines, and then the post
Mm.
test was collected, and
Okay.
they were explained with the protocol and how to do the procedure.
One group pre-test. Okay. Thank you, Vaishali.
Thank you, ma'am.
Next is Mr. Suraj. He'll be presenting his.
Thank you, sir. Good afternoon.
We will share the PPT. Just wait.
Okay, sir. Just a minute.
I'm sharing. Suraj, I'm sharing your PPT.
Okay, sir. Okay, sir.
First.
Okay. Thank you, sir. Good afternoon to all. Myself, Suraj Kumar, and I would like to thank our college, PANNA Subharti Nursing College, and so today I'm going to present my paper presentation, and my topic is first title of the study. My study is impact of using communication board on the level of satisfaction among mechanical ventilator patient. It is a quantitative study. And now introduction. A communication act is a component of communicative behavior, non-vocal or verbal, that is directed from one conversational application to another in an attempt to convey a message and exchange a group of communication act related to the communication of a single idea. Interpersonal communication is considered to be a fundamental human behavior necessary for normal psychosocial functioning. Next, need for the study. Need for the study. Effective communication aids can bring back the level of satisfaction of the patient. Hence, the investigator decided to find out whether the electronic communication board has the potential to improve communication and the level of satisfaction among mechanically ventilated patients. Next. Now, statement of the problem. A study to assess the impact of using communication board on the level of satisfaction among mechanically ventilated patient at selected hospital merit. Now coming to the objectives. First, to prepare and validate the electronic communication board for a patient with a mechanical ventilator. Next, to assess the impact of using electronic communication board on the level of satisfaction in the experimental group as compared with the control group. Third is to find out the association between the level of satisfaction with their selected socio-demographic variable in experimental group or control group. Next. Now hypothesis. All hypotheses were tested at 0.05 level of significance, and hypothesis 1 is the score of the level of satisfaction will significantly higher among mechanically ventilated patients who use electronic communication board than who do not use electronic communication board. And hypothesis second, there will be no significant association between the post-test score of the level of satisfaction among the experimental group with their selected socio-demographic variables. Next. Now variables. Dependent variables is level of satisfaction, and independent variable impact of communication board. Demographic variables, age, sex, education, occupation, and length of ICU stay. Now research methodology. So it is a quantitative approach, and research design quasi-experimental post-test only control group design setting in Subharti Hospital, both means experimental or control group. Now population patient who are on a mechanical ventilator, total sample size is 30. 15 is control group and 15 is experimental group. Sample technique, known probability, purposive sampling. Sir, backside data analysis. Last one, sir. Okay, organization of data analysis. There are 4 sections are there. First is description of frequency and percentage distribution of socio-demographic characteristics, experimental and control group among the clients under mechanical ventilator. Then section 2 is description to assess the level of satisfaction among experimental control and experimental group and control group. Section 3, comparison of mean and standard deviation of post-test. Section 4, chi-square value showing an association between the post-test level of satisfaction with selected demographic variable among ventilator patient in the experimental group. Next. So, next. Section 1, according to age group, according to socio-demographic. Hello, sir, can you hear me?
Yes, we can hear you.
Okay, ma'am.
You can tell the results and results. No need of demography variable. You can go with.
Sir, actually, I am not able to see content.
No.
Can
You
you
can.
please? Okay.
Yeah, you can tell this one.
Okay. Now, level of satisfaction among experimental group. Both group, experimental group or control group. Those means communication board only provide the experimental group, and after that this is a score and level of satisfaction post test. Then 1 to 20 very dissatisfied, and in the level of satisfaction in experimental group, majority of the very satisfied, age group of 40 to 60 score. Next, sir. Now comparison of mean and standard deviation of the post-test in experimental group. In experimental group, the mean level of satisfaction 48.53 and standard deviation 2.56. In control group, mean is 26.53 and standard deviation 3.75. And provide the communication board experimental group only, and that unpaired t-test value is 18.41 and table value is 2.05. Now, problem faced during study. Researcher means during my study I faced more problem, means more problem to get the sample, while preparing the communication board and collecting the data. To overcome the problems, researcher went to the ICU whenever the patient for admitted, irrespective of the time spent to the get of the sample for the data collection. Limitation: the study this study was limited to the mechanical ventilator admitted in Chhatrapati Shivaji Subharti Hospital, Meerut. This study was limited to quantitative approach. The sample is 30 only, limited, and the study period was 3 weeks.
Okay, Suraj?
Yes, ma'am.
Yeah, thank you.
Okay, ma'am.
मुझे बस I just want to ask one thing. Can you just explain the various components of the communication board?
Ma'am, in communication board means like difficulty breathing or anxiety and sleeping pattern means if a patient is having problem like headache and difficulty breathing, anxiety, constipation, and hot or cold, these are the components.
Okay. What made you to think of this for why ventilator patients? Why communication board for ventilator patients?
Ma'am, actually, patient because of due to the CPAP mode, due to the ET tube, patient is not express their feelings. So due to the communication board, they are means
Relax.
through थ्रू द कम्युनिकेशन बोर्ड वो अपनी फीलिंग्स मतलब स्टाफ के या डॉक्टर के साथ में शेयर कर सकता है
चलो
थ्रू
ठीक है
कम्युनिकेशन बोर्ड
थैंक यू ओके थैंक यू सर
Thank you, ma'am, for your valuable time that you have spent with us in evaluating the three paper presentation. Thank you so much, ma'am.
Most welcome, sir. It's my privilege to do this.
We can meet you on tomorrow and day after tomorrow also. For your...
Yes, sir. Sure, sir. Sure, sir. Thank you, sir.
Thank you, ma'am. Thank you. So, till now, you all are watching about the blended mode of teaching and amelioration in nursing education research that we are focusing on the platform. So it's my privilege to be at this moment to thank each and everyone who has participated on this first day of this conference. I extend my thanks to Susan ma'am and Thangam ma'am and Rajalakshmi ma'am for being a part of this first day conference. Especially I thank the organizing committee and the principal for giving the chance and arranging this conference in a great manner. So once again, I thank each and everyone, those who are watching this virtual conference, that you join tomorrow also at 12 o'clock. So we can have the next session on the second day session at 12 o'clock. So by this, I conclude today's first day conference. Thank you. Have a nice evening. Good night.